We're going to get started as soon as Representative Wallner comes back into the room. All right, it being 1:05, I'm going to call into session this work group on from Division 3. We have 7 bills to go over today, and some of these are pretty complex, so it could take quite a while. We're going to take them in the order that they're listed. So if you're here only because of SB 459, you have my apologies up front, because you're going to hear a lot of stuff that have nothing to do with 459 for the next many hours. So we're going to, so where are we? Now, we are at a place I don't really like being at. We got these bills, most of these bills, last Thursday. We've only had a chance to talk about 2 of them. So the other 5 are all fresh to the committee. And so, and many of them over the weekend, the vice chair and myself have coordinated with Mr. Ripple, our representative from LBA, to draft an amendment, or I have drafted in a Word document something I would just call a discussion draft for us to look at. So we have today to talk. I don't anticipate voting out anything other than maybe SB 275, because it's not on the calendar for tomorrow. But other than that, we're going to prepare ourselves so that we can have any amendments done, so that we can vote out amendments tomorrow where appropriate. So that'll make us ready for the Wednesday finance section. So if there are no questions on what we're doing, let's go ahead and start a hearing on SB 275. Is there anyone in the audience that came to talk to us about 275? So Representative Irf, from your seat, would you tell us what you think 275 does, and if you have any issues with it?
Thank you, Mr. Chair. What it does, it's basically an a fund, opioid abatement fund, from which people can apply for grants to work on reducing opioid abuse. And the one area of the bill that I question, it's not really question it, but I think should maybe extended, is section 3 that relates to it says it relates to the duties. It's actually changing around who can apply for the grants. And on line 20, number 16, subsection 16 of, what is it? RSA 126-A:86I, B, paren B, says that public school programs can apply for these grants, which makes perfect sense. But it would seem that that should be more inclusive of at least charter schools and other kinds of educational environments, since I'm assuming that everybody wants to have kids be able to get these grants to help the students, as it says, and services for students with OUD and any co-occurring SUD/MH issues, or who have been affected by OUD and any co-occurring SUD/MH issues within their family. There are also a couple of little minor technical things, like the letters RSA aren't in there, but I'm sure that's what's intended. Yeah, and that's it.
Thank you for doing that. And Division 3 doesn't deal with educational programs, and so I'm unfamiliar with what the appropriate term of art is, or should be, on line 16. If we intend for educational settings greater than just the public schools to be able to apply, I don't know if the language as it's described there is adequate or sufficient. Mr. Ripple, do you happen to have any insight into whether the phrase public school programs is sufficient to include things like charter schools and other educational settings?
This is one that OLS, I believe, is working on now for an amendment, and that was one of the issues they were going to address. And I think I asked them to include language such as something like all public and non-public schools, so that would cover everything.
All right, so we can just effectively recess this bill and while we await for the amendment. Is there any comment from the representatives on the committee?
Good idea.
Okay, so I'm going to put SB 275 in recess, awaiting the amendment to be delivered. With that, we go to opening SB 407. This is an act relative to expanding Medicaid to include certain postpartum health care services and making an appropriation therefore. So Representative Irf, do you want to do something similar to what you just did on 275 to give us an introduction on what 407 does?
Sure.
And I think we have Mr. Lippman here. For you would be available to introduce this bill and tell us what you think it does and what the department position is, right? So let's do that instead. All right, come on up, please. And we'll, of course, need your name for the record and everything.
Good afternoon. For the record, Henry Lippman, State Medicaid Director. Senate Bill 407 fills in an important gap for individuals, women who deliver a baby, who have income level just above 138%, but below 196%. They're only given 60 days worth of coverage after they deliver the baby. Many of the conditions, and this is a fairly small population for our actuary in terms of the fiscal note that's in front of you, estimated 571 women in state fiscal year 23 would apply to this. I noted to Kevin, I think the chair, you had a question on that, what the number was, and we've seen as high as 761 going back to 19. But essentially what this does is, within 60 days, some conditions such as mental health, SUD, but also cardiovascular conditions not necessarily fully been able to be taken care of. I guess from an equity standpoint, and someone has a little bit more income, whether they be employed or in the Medicaid program, who can qualify for granted advantage would continue to have coverage, or if they were poor enough, if you will, below the 138, they would continue to have coverage. So it kind of filling in the donut hole here of coverage for those women who only are allowed 60 days of coverage, whereas others have a full year.
May I ask you a question?
Please.
What was you refer to it as a donut hole? Let's use the phrase for a moment. Did this donut hole exist prior to the pandemic? Are we essentially expanding the Medicaid program? That's really what we're doing. We're expanding the Medicaid program. Is that correct?
In part, but what's new, the American Rescue Plan of 21 provided for the first time funding on a federal level to support the match to do so. And I think Vice Chair has a copy of this map, and I've left others with Kevin Ripple. It's something that many states, both red and blue states, are addressing based on the availability of federal match that didn't exist historically. It's for a 5-year period. I think the bill's been amended to my understanding, to only run if New Hampshire were to adopt it to that point. We understand why that would be the case. And it's fairly small dollars. Again, a lot of the things that aren't taken care of aren't big dollar ticket items during that period, but they're important for the mom in raising the child, and they're important for the mom's health herself. I think there's a mortality issue that sometimes emerges in a subset of that smaller population. So if we're talking about 571 women in state fiscal year 23, a subset of them will, need services and to maintain their health.
Do you have a question, Representative Weiler?
For the record, can you go over the three different funding areas that you said there's a donut hole? So
Okay. So individuals who have income above 138% of the poverty level and up to, but less than 196%, that's where the 138 to 196. Yes, that would provide beyond, they would, if you will, equalize them to others who have a little bit more money or have a little bit less money.
Do you have any understanding of, I'm just curious, 196 is a peculiar number. Why, how did that number get picked? 196% instead of 200% or some other?
I believe, well, I can confirm this with you, but I believe it's historically what the sort of the federal limit was that New Hampshire adopted. I think sometimes states have the ability to go up a little bit higher, but there's usually a threshold amount, and I think that was for that particular one. New Hampshire, I think, adopted the threshold amount that was in the federal program. But I'll confirm that.
It's not urgent. It just is just an odd number and makes me wonder. Do any other committee members have any questions on this bill? Representative Long?
Thank you, Mr. Chairman. You stated a number of 2019, 761 cases. Is that the cases in the whole, or is that the,
So this in what we're projecting in the fiscal note is 500 and 500. I'm forgetting my number, Kevin. Is it 561? I believe is the number in state fiscal year 23. That's what our actuary, in looking at our enrollment, is projecting would fall into that. What I was just trying to, by talking about 2019, what I'm trying to just bring up that the number can fluctuate based on the number of births in the year and, what income levels people who deliver babies have. So, in terms of our fiscal note, we did add some dollars to the base 561 to account for that. There could be fluctuation. Do I have that number right?
thank you.
And just to be clear, that number 561 or 700 from a couple of years ago,
Yeah.
that's the number of women in that donut hole
Correct.
that would give birth or expected to give
Right.
birth, not the ones that would expected necessarily need these extra services over the following year.
Correct. Like anybody else with health insurance, there's only a certain portion of the individuals have to end up using the services.
All right. So any other questions by the committee? I would like us to take a straw poll on this. I'm favorably disposed towards this bill. I don't know where the rest of you are at. So I'm gonna ask you to raise your hands if you support 407, and then after counting that, we'll ask for a show of hands if you oppose 407. All those in favor, raise your hand. Those opposed? So it looks to me it's unanimous amongst the people here. And then Representative Wallner, would you give me, would it be okay with you, or would you have a problem if I went ahead and we just, would you be able to support an official vote on this today? That we could just get it out of our way so tomorrow isn't as jammed? Representative Weiler, can you support a vote on this?
I can.
Representative Wallner, are you okay with the vote? Okay. Okay, so I will allow Representative Weiler to take our vote when he's ready.
No amendment.
Correct.
Wait a second. I'm sorry, I'm forgetting my protocol. I need a motion.
Oh, I'll move OTP. I'll move we recommend OTP.
Okay, thank you. Is there any further discussion? I don't see any further discussion.
Motion is not to pass. Motion is not to pass on Senate Bill 407. If you're in favor of ought to pass, you'll say yay. If opposed, you'll say nay. Representative Erf.
Yes, yay.
Representative Weiler, yay. Representative Bean. Representative Wallner.
Yes.
Representative Long.
Yay.
Chairman Edwards.
Yay.
6-0.
Thank you. With that, we'll recommend OTP to the full Finance Committee. Is there anyone who wants to write the committee report on this? You guys want to do? You guys want to do some work? Okay. You got it? All right. Thank you. Thank you. All right. So that closes 407. Thank you. So let's go on to 416. This is relative to behavioral health assessment and treatment for children in out-of-home placements. Is there somebody in the audience that came wanting to talk about this? Please step forward. Senator Whitley, it's good to have you here.
Thank you, Mr. Chair. It's so good to be here. For the record, my name is Becky Whitley. I'm the senator for District 15 and the prime sponsor of this bill. And with me, I have Rebecca Ross, who is the head of the Children's Behavioral Health Bureau. And we work together on this bill with a few other advocates for children. This issue was actually brought to me by the Office of Child Advocate, trying to think about how do we better serve our kiddos who are in residential treatment and out of state. Even though we are building our system of care, there continues to be kiddos in out of state facilities. So we wanted to get something that was workable for our school districts. So under special ed law, school districts have certain responsibilities to do these assessments. So it was very important to have the Department of Health and Human Services and the Department of Education at the table. So we made sure that each agency had the appropriate responsibility in here. So you'll see that the House did amend it in the policy committee to reflect some of the changes requested by the department. So happy to take any questions, but it's really just trying to better assess children so we can get the right treatment for them and, hopefully the less expensive treatment.
Do you have any testimony you want to volunteer, or
We're-
should we just ask you questions?
Go for the questions.
Okay, so I'm going to admit my ignorance out of the gate here, because this is a lot of education policy, and I'm not steeped in education policy. So I focusing on page 2, paragraph 3, the new paragraph about dealing with individualized education programs. And this looks like this is just yes or no, and so I know where I'm going. Is this a new requirement?
No, what we're trying to do is make clear that the school district does have certain responsibilities when the child does have an IEP, but we're not expanding, what the school is required to do. We're just clarifying it within the context of this required behavioral health assessment. And if you may remember, of course, education is not, before this committee often, but there is federal law and then there's state law with special education.
Yeah. Okay. So you're convinced this is a clarification of the existing obligations, and that if I went to my principal and talked to her about this, she'd say, yeah.
Correct.
Okay. Are there any questions, Representative Erf?
I will say, I'm sorry.
I'm going to take a timeout and recognize that Representative Walls has joined us, and welcome. So we happen to be on the third bill of the day, 416. We have recess on 275. Go ahead.
Mr. Chair, I did want to say, if you look on page 2, line 8, about who can actually conduct these FBAs, that language was actually requested by by school district to make sure it reflects who actually conducts these assessments in schools. So we want it to be reflective of the practice in schools. So it can be, the assessment can be performed by individuals who are qualified to perform the assessment, and there are certain qualifications within Medicaid, and that may include, but is not limited to, a board-certified behavioral analysis or a psychologist. And we added psychologists because often psychologists are the ones doing these assessments in schools.
Representative Earth, did you have a question?
Yes, thank you, Mr. Chair. And thank you for taking the question. So can you tell me under what authority an FBA is required for every IEP special ed student?
It's not required for every special ed student.
By putting in this new section 4 into that RSA that's referenced there, 186-C:7,
Mhm.
that is requiring it.
No, it says if the team has, so the IEP team is made up of parent, teacher,
Read the entire clause.
yeah, has determined, if the team has determined a positive intervention plan is appropriate after review of an FBA.
Ma'am, did you hear what you read? You just read? After review of an FBA. How can you review an FBA that doesn't exist?
So what I know of special ed law is that this isn't creating it, but it's the team that determines whether that FBA should be conducted.
So where you're putting this into the law, into our statutes, the statutes require those things to happen for an IEP, which in this case
Yeah.
means you're now requiring an FBA for every IEP.
I'm sorry, I don't read it that way. I don't read it as creating a new requirement. I don't know if you wanted to comment on that.
I'm not familiar with the Department of Ed portion of it sufficiently to comment on that.
I will say that the Department of Ed helped write this, and that is not how I understood it. That's not how they understood it.
Okay.
Requiring an FBA for every child.
The commissioner seemed to have a different point of view, and unfortunately, I guess nobody else here from the Department of Education to address that, so we'll need to look more into it more deeply.
We
So
worked
is it-
with Rebecca Fredette, who's the head of special ed at the department.
Is Rebecca here today? Or Fredette? I think I emailed her like late Sunday, so it would be stunning if she were here. Okay, Mr. Ripple, did we do an amendment, get an amendment ready for this?
Yes, you have the amendments that we talked about before the meeting. Would you like me to hand out one or both of those?
Why don't you hand out the one that we agreed we'd go with? And by go with, don't overread what I'm saying. It's the one that I said we would discuss. We haven't made any determinations because I am not steeped on educational policy. Oh, welcome.
I was across the hall, sorry.
All right, so Representative Earth was just asking a question, and we all acknowledged in the room that we needed you. So that's why you're here. So we're gonna back up and rewind and have Representative Earth ask you the question.
Sure.
Thank you, Mr. Chair. So I'm trying to understand, it seems to me that when you put section 4 into RSA 186-C:7, which is basically the requirements that have to be met when putting together an IEP.
Yep.
When you say that if the team has determined a positive intervention plan is appropriate after review of the FBA, that requires that an FBA have been performed. The only way that an FBA would have been performed if it was performed for every student in the IEP, which is where this new clause is going into the law.
Thank you for the question. There is language in 186C that refers to a functional behavior assessment. So it's,
I gotta stop you. The
Sure.
clerk needs your full
apologize.
name and your title. I'm sorry.
nope, that's okay. I forgot. My name is Rebecca Fredette. I'm the State Director of Special Education. So
And
186.
can you spell Fredette?
Sure. FREDETTE.
Thank you.
So in 186C, it does discuss functional behavior assessments, and a team will determine to complete a functional behavior assessment if it is needed based on behaviors or a manifestation of their disability. So we had put this in that if it is determined that they need a positive behavior plan, they would put something in. But this language doesn't say, to me, does not say that it has to be done. And we referred them back to the CFR that relates to all discipline procedures regarding a functional behavior assessment.
Okay, the CFR is the federal law, right?
Yes, it is.
I have that in front of me as well. If you could refer to me where in 186C it talks about an FBA, that would be helpful. It's certainly in C:7, it does not.
I apologize. Did not know about this meeting until this morning, so I did not have anything with me. I was across the hall at Division 2, so I do not have it with me. I can look it up and get it to you, but I know that you're on a time frame, so.
No, that'd be great if you could just get to us. I did send you an email with all this information in it as well this morning.
Yes, I got it this morning, and then I went to Division 2.
No,
Well, I went to
I'm so
Division 2.
sorry. We were in a scurry mode.
Yep,
We
I
didn't have this bill until Thursday, and this is the first time we've had a chance to talk about it. So we're all just kind of in a little bit of a scurry.
Sure.
What would be the impact if we just simply deleted everything under paragraph 3, new paragraph, and just deleted that whole section from lines 12 to 23? What bad stuff would happen? What would we break?
If I haven't looked at this bill in a while. If I remember correctly, it was requiring that pieces be put into the IEP related to a behavior plan, and this would make it so that it was not required, that it was only if the IEP team determined that it would be put into the behavior plan, into the IEP, excuse me. So if they looked at the functional behavior assessment and said, no, this does not impact them educationally, it has nothing to do with their disability, they wouldn't be required to put it in the individual education program. They would be able to not put it in.
I'm so sorry. In 10 words or less, what would we break if we deleted this paragraph?
I'm happy to try to answer that one. The point of adding the clarity was to make sure it was clear where the line between the school district and the department or DCYF or behavioral health was drawn, so that if it fell under the school district, it would have certain things included. And if it did not, it would be clear that then it was for DCYF or behavioral health to get the functional behavioral assessment, consistent with what DOE would be getting.
Okay, but so there's no change in the responsibilities and relationships. This is just a clarification. That's what I've heard.
There is a change because prior to this bill, there is no statutory requirement for DHHS to do any of the functional behavioral assessments. But there's been a lot of confusion about when the school district does it, what's included and what gets passed on for kids who are also being served by the department.
So, Mr. Williams, if you could just shake your head, yes or no, does the department support 416? That's all right. He just answered it. What I heard you just say is that you have been in support of Senator Whitley's drafting of the bill, but the department has not taken a position in favor or in opposition. All right, Ms. Ross.
Thank you. In principle, we certainly support the use of FBAs when they're appropriate. However, the department would need the necessary resources to enable us to implement this.
So I completely agree with what you just said. But one of you, actually, in the Senate testimony, I can't remember who it was. I think it was, well, I won't say who I think it was, 'cause I'm not sure, actually spoke about the cost of these FBAs and pointed out that they're not, this is in the Senate testimony I'm referring to now in the report that came out of the Senate, that they're not inexpensive to perform. And you wouldn't want to be requiring every student with an IEP to be having the FBA. I assume that's correct. Okay.
Correct.
So if you could just help me, you don't have to do it now, but if you could go through and explain to me how, where the ruling, because if I just read the very simple parts that I read, which is basically 186-C:7, and then also 34 CFR 300:530, that whole thing, F. None of that makes clear that an FBA is otherwise required. Is not otherwise required. In other words, you're putting this into C7, which are the requirements, if I understand it, are the requirements for an IEP, the things you have to do for an IEP. So as soon as you put something in that requires an FBA, you're, in my world, you're adding that. Unless there's some other place that says it's already, what was just mentioned, that only in a certain circumstance, something like that. So if you could just point me to, not right now, but if you just send me that information, I'd appreciate it.
It's actually in the bill. I just had a minute to read it. Well, so if you look at section 5, it says under 34 CFR 300.530, schools are required to conduct a functional behavior assessment and provide behavioral intervention services any time a child is removed for more than 10 days. So it's referencing that. That's when we would do a functional behavior assessment. It is on line 16 of the bill on the first page. Number 5, section 5.
Exactly. When they're removed,
Yes,
not when they're coded.
right. So that is what, but so then this clarifies more when we add on section on the back in number 3, when you add that on, it clarifies that if, when you look at that functional behavior assessment, you determine that their education needs that positive intervention plan, then you would put those pieces into place.
Okay,
So it's
let me
the
ask you this then. So
Sure.
if you go to look and there isn't one, then you just skip over it?
Yep.
Okay.
So I'm going to read just a piece of the LBA write-up on this and see if you agree with it. The LBA wrote, the department states that traditionally the FBA has been used in education and specific developmental diagnosis support. The department further states that if the intent of the bill is to broaden the FBA beyond its traditional uses and into the behavioral health arena, there will be likely a significant state cost. The department did not identify the extent of any such additional costs. So would you say the intent of this bill is to broaden the FBA beyond its traditional uses?
Yes, absolutely. In the context of behavioral health treatment, not exclusively in education. So for a youth who may be struggling with behavior at home or in the community, but is not at school, it would certainly be an appropriate evaluation to help assist in developing the plan of care for that youth. So it's looking outside of the school arena to home, community, and residential where children and youth may be struggling.
So the dilemma that I wrestle with, and I'll look to my committee members to help me get myself a little settled on this point. It seems to me like we're looking at a significant increase in state costs, and we have no idea how much that is. Right? That's sort of a fair summary of where we're at, right?
With the amendment, we have not provided the updated fiscal note worksheet. We have one in the works and we'll be providing that. I think we can come up with a lot closer than no idea at this point now that we've narrowed it down and identified the scope through amendment.
When might that sheet be prepared? Because as I understand my deadlines, I'm done with this tomorrow afternoon, and then I got to turn it over to the full finance committee.
We can get it to Kevin when I get back to the office.
That's pretty good. Are there any questions on this? I'm about to show you an amendment we've drafted, but I want to have you all have an opportunity to ask questions on this point. Representative Erf, did you have more?
Yes, thank you, Mr. Chair. So if on line 15, we open that line up with something to the effect of, if an FBA exists for the student, and would
And.
that work for you?
Yes, that would.
What did you just say?
On line 15 of page 2, if an FBA exists,
If an FBA
exists for the student, and then you continue on. In other words, if that's essentially what you just said from section V back in section 1 was doing. So this would just clarify that in fact the FBA has to exist before you go and look to see if it
That's correct.
recommends. And then that makes sense. Then what you say makes sense to me.
Yes, it does.
You all can stay there. Mr. Ripple handed out an amendment, 1738. 1738 is an amendment that basically just strips out this entire paragraph. What I thought that would be doing is just avoiding the significant state costs where we don't have an estimate. So we're going to be able to wait and get more detail on that. And also, Representative Erf has suggested a different amendment to make it clear that if the FBA exists, it can be used. If it doesn't need to be generated. If we did that amendment, would you all be in support?
Yes.
So if we're removing section 3 that references the Department of Education in that IEP language, that would not have any impact on the DHHS estimates of costs that we'll be providing, because that would still be the additional FBAs through the Department of Health and Human Services. I think I'll defer to Rebecca on the other part of your question.
And the language that was proposed by Representative Erf is fine with us. Eliminating this, we had put this in to allow for districts to put language into the IEP if a functional behavior assessment was done. So if they determined that they did not need one based on their educational needs, but somebody from DHHS came with a functional behavior assessment and said, we think you should look at some of this information, then that allowed the IEP team to look at it and say, yes, we could add something to the IEP because this may start to impact them, or it has already started to, and this is going to help us.
So, thank you. So Mr. Ripple, let me ask you. We've meandered a little bit, but we've stumbled upon a different amendment. Do you think what we're talking about, and would you describe what you think we're talking about back to us?
Well, so what I've heard so far is Representative Erf's suggestion that on page 2, line 15, the new line would effectively read, if a functional behavioral assessment exists for the student and the IEP team has determined, et cetera. So is that the only change that you're talking about at this point?
I think so, Representative Erf, yeah?
Yes.
Okay, and is it your understanding, Mr. Ripple, with that language that we would probably avoid the state cost?
Well, that's the part that I'm not sure about, because it sounds like the HHS costs are located elsewhere in the bill.
Do you all want to respond to that?
Yes, this is creating a completely new service for most DCYF out-of-home placement cases, and that's where the costs would lie in the first couple sections of the bill.
So I understood the amendment to not be creating a new FBA requirement, because we're going to say if it already exists, it can be referenced, not that it must be created to be referenced.
That would be in the educational setting, but the bill is establishing an FBA process for the behavioral health or mental health system that would be a new service and would come at a cost to the department.
Okay, so this is where I think we're at. If we can have, I don't want to stir OLS up if we don't need it. But so I do want to take a straw vote, and the straw vote I want to take is yes, ma'am, please.
I apologize for interrupting. On the cost, I appreciate you turning that around so fast. I did want to just bring the committee's awareness to the effective date. It shall not take effect until January 1st, 2024. And that was at the request of the department, so they could, figure out how to pay for this. It may be that it could be, well, I don't want to put words in your mouth, but there are different ways that this could be paid for through, a negotiated contract with the managed care companies. There are different ways that it could be paid for. So, I just wanted to point out that it won't take effect for a couple years to give the department the availability, the time to really cost this out, if that gives the committee any solace.
I would add that it's the cost as well as the workforce, that there would have to be substantial efforts to recruit the workforce to be able to meet this obligation, which is part of why we asked for that additional time. But we're still going to have to identify a revenue source in order to be able to establish this benefit.
And again, it's not required for every child going out of home. We also did another amendment at the department's request saying that it was if necessary. So it's not required for every single child who's going out of home. So we thought that was a reasonable agreement. And again, if you're thinking about the cost, backing up to the whole point of this is so we can save costs, right? We want to figure out what the kids' needs are so we don't place them in a $30,000 a month placement out of state in Utah. I'm not saying that happens, but the whole idea of it was there are a group of children who are receiving out of home care at a very high cost. And if they can be better served in New Hampshire, somewhere else, that's less expensive with their needs met, we want to do that. So this is the balance here.
So I'm asking this respectfully.
Sure.
You're making some assumptions on what we can do with an FBA if it were available that we don't really have history with. So it is a little bit of a hopeful guess also, isn't it?
Well, it's more than hopeful. I mean, our former Office of Child Advocate, she was a nurse. She has reviewed these cases. She knows the needs of these children, and it was her recommendation to do this. So it's more than a hope, I would say.
I'm wondering about language.
Go ahead, Representative Weiler.
Page 1, line 16, and that paragraph talks about more than 10 days removed from school for more than 10 days. Should that be removed from home for more than 10 days?
That is tracking current federal law. That's talking about the special ed context. It's essentially just saying what's in federal law.
If I'm not mistaken, Representative Weiler, that relates to the Section 3 that I was talking about. I don't believe that relates to the Section 2, does it?
Correct.
So that was how the FBA gets triggered that impacts Section 3. And as long as we stayed in Section 3, that if the FBA already exists, then the Section 3 stuff will apply. But the part they're talking about now is the Section 2 part. That's the part that relates to DHHS.
Correct.
And what they're talking about.
Correct. Thank you, Representative.
Thank you.
I'm looking at page 1, line 21, where it says, therefore, this act directs the DHHS to expand the use of functional behavior assessments.
When clinically indicated.
Yeah. So is that the cost driver right there? Is
Correct.
that the thing that's okay?
Correct.
So, Senator,
Yes, sir.
I have almost no time, and I really need to see numbers before I am comfortable voting for this. So, in case we don't get the numbers in time, what I'm thinking we could do is delete this paragraph 6 on line 21 through whatever 24 from the House version, and since it's in the Senate version, we could take it to committee of conference, and that would buy us time to get better math. How do you react to that?
If that's what you feel like you need to do to move the bill, then, that's fine. And I guess, we will deal with it in committee of conference. I'll defer to you on strategy.
All right. Well, if we go to committee of conference, it's a partnership. So Representative Wallner, you have things to say.
Well, I was just going to ask, when do you think you can have the cost for us sometime today? Was that what I understood?
Yes, we've done some preliminary work and just need to wrap it up, but we should be able to get some ballpark numbers to Kevin today.
I mean, personally, before I make any decisions about taking this paragraph out, I would like to see something about the cost.
Okay. So I think we've done about all we can at this point. I want to recess 416 and we'll pick it up tomorrow. Hopefully wait a second.
Just briefly before you do, could we get some agreement or get a measure of it, whether there is agreement on the small change to line 15? Because I think that should be in there regardless of which way we decide to go with the other pieces.
So what I was thinking about that is that if we ended up wanting to remove section 4, I'd rather do both those things in one amendment because the amendment you suggested didn't seem controversial.
I completely agree. I just want to know if it's, let's confirm that it's not controversial. Not do anything, just confirm here.
I'm good with Representative Earth's amendment.
So I'm becoming more perceptive and sensitive with age, I think. But okay, so I don't want to keep throwing things at Kevin and OLS unless we have a good cause. So we'll recess 416 until tomorrow with the idea that sometime within the next few hours we'll get some math on this.
Representative Edwards,
Yes, ma'am.
if Ms. Ross was able to have figures or some information later this afternoon, could that be distributed to us before we leave here today?
I would love that. I just don't want to put any more pressure on them, you know. The sooner the better, I think, is the case. And if we haven't recessed the whole work group today, since this bill is recessed, I think we could pick it back up if we get more data.
Thank you.
That brings us to the bill I've been told I should not call the omnibus. So the not omnibus bill, SB 430, has many items in it, and Representative Earth over the weekend walked through them. Before we get started with sort of the Earth driven discussion of this 430, do you all have any specific sections of 430 that you already know you'd like to have discussed? It's a big bill. I think this is why it took HHS 11 and a half hours to go have their hearings. I would like to not do that. Yes.
I would like to see us focus on ones that have financial impact and not on strictly policy issues.
And I'm generally okay with that. I just have not sorted these. And so I'm basically asking, have you sorted these into fiscal and non-fiscal? And do you have a list of the fiscals you want to talk about?
No, but I bet Representative Earth has.
Representative Earth's pretty great. So, so why don't we, I know that he wants to talk about paragraphs 3, 6, 22, and 55. Is that right?
That is correct, and one of those is policy, but the other 3 are all fiscal.
Are there any other paragraphs to add to that discussion?
Not that I pulled out notice.
6 and what?
3, 6, 22, and 55. Okay, so this is, I did do a discussion draft, I think, on paragraph 3. And so when you think we're ready to talk about that, we can hand those out. Okay. And I'll give Harry one, and then you get one, and then I get one, and you get one. You give those to.
I do have what I think is that same language in the form of a formal amendment. Would you like me to hand that out now or not?
So you took this and made it a formal amendment?
If the language that you passed out was in your email the other day, then
Yes, sir.
yes, I have that.
Oh, well, let's do that then.
And I also have, today we issued a revised fiscal note for the bill as amended by the House, so I'll hand that out at the
On
same time.
430?
Yes.
Okay, please. So I'm going to just do a general overview on what Amendment 1743 does to paragraph or section 3 of SB 430. We all know that we're supposed to do ready, aim, fire. This bill feels like a fire, ready, aim, because we're going to charge that a pilot program gets started just immediately, is authorized to just go. And I don't know the extent to which any planning for this pilot project has been done. So the inserted language, which is a little hard, actually, if you've got my copy of the Word document, it may be helpful because the bold shows you what changes got made between the section and this amendment. This amendment is just to replace all, so you can't really see what got changed. So what I did was essentially say that there should be a planning phase, and that after the planning phase, then the people who are doing the pilot project planning can come to the Joint Fiscal Committee and ask for permission to begin execution of the pilot program. I thought that might be necessary to have a more successful pilot and have us understand better what the costs of it may be. And I'll let you just read it unless you want to go line by line on the changes. A key item is on 6, where it's in bold. If the department determines that all necessary coordination for the pilot program has been sufficiently completed, the department may make a request to the Joint Legislative Fiscal Committee to begin conduct of the pilot program upon an appropriate effective date. The pilot program shall not begin until approval of the Joint Legislative Fiscal Committee. So they could do that very early in this process, or later if they need more time to really feel like they've got their plan where they want it. Any thoughts?
You still put the money in there.
I think the money said it would lapse if not spent, right? So the funding is available. They can do so the fiscal committee would be allowed or able to let them start because the appropriation would already be there, and anything that's not spent should lapse. Is that clear to you in the way we've got paragraph 6 written?
Well, in 7, it actually does say that the appropriation shall be non-lapsing and continually appropriated to the department. So we could have that redrafted with that section removed if you.
Yeah, I should have caught that. I would want that to be lapse. Representative Walls.
Thank you, Mr. Chairman. Just trying to understand why we're doing this, because I don't know. This is not my bailiwick. I'm not familiar with the details in this. But in looking at this, nobody in HHS raised these concerns. And I'm wondering if a pilot program, basically there's one out there that they can sort of pick up and not the program they can just pick up and drop in. It's been done elsewhere. It's not something that's novel. And we don't need to try a pilot program before we run the program because everybody knows what the program needs to be. And there's nobody here to testify. I don't know. I'm just asking, why are we doing it this way?
I think you've actually raised a very good question. You and I are both making assumptions. Your assumption is a happy one in that they already know how to do this pilot program from other examples and they're ready to go. Mine is the more cynical, having never seen a pilot project get rolled out quickly and effectively. I'm just trying to make sure that we have an effective approach. Is there anyone in the department who's able to speak to the maturity of the planning for this pilot program?
I I also want to clarify, Representative Edwards, I'm not making the assumption. I split the prefaces by saying, I don't know. I'm just trying to look at it analytically and think, if it ain't broke, don't fix it. Why are we trying to fix something that nobody's come to us and said there's a problem? That's what I'm trying to
We're
figure out.
about to hear if it's fixed or not. So,
Thank
Mr.
you.
Williams, could you?
Yes, John Williams, the Director of Legislative Affairs for the New Hampshire Department of Health and Human Services. Thank you. On Section 3 of the bill, that section actually was generated as part of last year's legislation, Senate Bill 162, which required the department to engage key stakeholders in developmental services to develop a plan moving forward to address the issue of children who are age 18 up to 21 who, although in need of developmental services, are outside of the school districts for responsibility for paying for those costs. So this is to fill in a gap for those services for that age cohort. The plan was developed by working together with this group and eventually translated into the legislation you see before you with the cap of 20 individuals. That's what the department estimates will likely be the outside of the cap of those being served, with an understanding that there would be a robust report that would have to be developed and provided to both the House and Senate Finance Committees as well as the policy committees on the metrics before we take the next steps building this into the 24-25 budget.
So I'm a man of fewer words. So you're saying, yes, this pilot program is ready to go.
Yes.
Okay, thank you. It's been a joy working with you for the last 6 years. Okay, so would you tell us, it sounded to me like you just said that you guys think that there's probably only 20 eligible individuals to begin with. And so when you pick 20 for this pilot program, that's nearly the universe of the people that need the program. Did I mishear that? Or how big of a potential population do we think will be served once this program is established itself as effective?
So pending this very important pilot moving forward, our department has worked collaboratively to address the the developmental service needs of children within that age cohort. We've been doing it on an ad hoc, one-by-one basis. The last I heard within the last 6 months, the numbers were around 5 or 6 individuals that we've recently served. However, as you develop a pilot like this, the need and demand will have to be reassessed as we move forward because it could be either a larger number of individuals who may seek and need these particular services. The reason why I was capped at 20 was a reasonable number balancing out as to what we expect to be participating in the pilot program. These are very costly services, and so there needed to be some level of cost containment, and that we settled on the cap of 20.
Could there be as many as 100 who would need this program once we establish its effectiveness?
We will need to further assess that through the pilot itself to give those numbers to you for a projection around that. There have been others outside of the agencies who have suggested higher numbers, but what we're seeing from the numbers that we're currently serving, we believe that we can service at least those who are in need at the present time within the context of this pilot of a cap of 20.
So we're going to incorporate the universe of known people who need this service, and that happens to be about 20.
I believe I suggested earlier that we're working on an ad hoc basis, one by one, that the numbers were smaller than that. I believe I mentioned 5 or 6.
Okay, so 20 is probably a very safe number then.
Well, assuming you're going to have 4 years from the 18th birthday to the 22nd birthday, you're going to have those 5 aging out.
Okay, so my concern in exploring the 20 is if the population's bigger, then the future program is going to be more expensive. That's one point. The second point was if the population is bigger and we're only servicing 20, I'd be worried about selection to make sure that the selection process was fair and not favorites. So it sounds to me like I don't need to worry about a really big program, nor that favoritism was used to pick the 20 eligible beneficiaries.
That is correct.
All right.
Mr. Chairman,
Yes, Representative Walls.
so as some of you know, I've been sitting on education lately, as well as in here and elsewhere. And one of the bills moving through education is a bill that basically expands services for disabled children between the ages of 18 and 22. And I can get into the details of it, but let me just say that the way it's running, I think it's unlikely that you're going to see 100 kids in this. You're going to see much more than what you've got, because the bill basically makes it easier for kids to continue to get services through the school year in which they turn 22. And there were two different versions. I'm struggling to remember the version that finally came out of the committee, whether it was on their 22nd birth. Oh, I believe it was at the end of the term that they turned 22, so that kids can stay in the program even longer and get services, so long as they don't graduate. And if they graduate, then they're out. But the belief is that a lot of these disabled kids would choose not to graduate, so that they could continue to get services through the school district through the end of the term where they turn 22. So we're talking the same age population here. I just want to let you know that in other words, they're expanding services on the educational side, which may impact and lessen the services on the HHS side. That's what I'm trying to say.
Thank you. Hey, Representative Irf, do you have anything you want to add to this paragraph?
Yeah, thank you, Mr. Chair. Well, I would either delete it or at least make the funds lapsing as opposed to non-lapsing, which they are now.
That silence you hear is me thinking. So I think I want to ask Mr. Ripple to just do a very simple amendment to this section to make the funds lapsing.
Yep. And I think that would be accomplished just by removing the sentence that says it shall be non-lapsing, because the default assumption is if there's no language, then the funds will lapse.
I'd be fine with that. So, so let's take a straw poll. Would the members of this committee be willing to accept an amendment that makes this $2.8 million lapsing versus non-lapsing? If you are in favor of an amendment like that, you'll raise your hand, and then I'll ask the opposite.
But would the funds, if the program is ready, as Mr. Williams seems to indicate, the funds could be spent immediately?
The spending could begin immediately. I don't think they could spend it all immediately.
Okay.
Right? This is not where you're going to write one big check. You're going to dole out money on a more periodic basis, I believe.
That is correct.
Okay. So the issue of lapsing versus non-lapsing is relevant, I believe. So would you accept an amendment to make these funds lapse as opposed to remain non-lapsing? Please raise your hand. Okay, that looks unanimous. Those that would not want the amendment, raise your hand. I'm not seeing any. So let's draft that amendment, and then I think we can dispose of this pretty quickly tomorrow. Just for confirmation, if we had the amendment, would you be in support of paragraph 3 as amended? Raise your hand, please. Okay, very good. Super straw vote. With that, we're going to close, or no, we're not. We are going to move within 4:30 to, you want to go to 22 first?
Yeah, they do them.
So why don't you do 22, because you actually know it better than I do. So Representative Irf is now going to talk to us about section 22.
Okay. So section 22, and I'm doing this from memory now, not by looking at the bill. Essentially, it's redefining the term personal care attendant under Medicaid rules. a personal care attendant is basically a home healthcare worker. And and I'm sure Mr. Lippman will correct me if I'm wrong, under the existing state of emergency and associated waivers, such as they are, family members can serve in that role and be paid, basically. And there's some possibility that after the state of emergency ends and or additional waivers can't be garnered, and again, Mr. Lippman can address this more accurately, there'd be a need for monies to continue to pay, to continue that program going. And my suggestion would be just to let the program end and things go back to as they were before this whole state of emergency, where family members took care of their family members without being paid for that.
So, I'm going to ask you to talk to this, Mr. Lippman, but as I understand the history of this, if we flash back about 10 years ago, people who needed at-home care had to go find a visiting nurse or somebody like that. And with the shortages on visiting nurses and the expenses of visiting nurses, it became perceived that it would be cost effective if there was a family member that could take care of that member. It was better to just go ahead and pay that family member to take care of the sick person, because it was a good economic buy and it helped strengthen families. And all of that sounds good. Is that an accurate summary of the history? Because then I want to keep talking if it is.
For the record, Henry Lippman, Medicaid Director. In part, it is, Mr. Chairman. There's the waivers, like the home and community-based service waivers. This is also, there's state plan services, which have also have a component. And the issue at hand here is that we find ourselves in a position where there isn't a workforce. They're entitled to a benefit if the family members don't step up in a certain situation. We could end up where the state has exposure, or kids or others could be institutionalized and incur a larger expense. What we're proposing here is under the, as the vice chair said, was under the public health emergency, we were able to get a special waiver. We're trying to negotiate another waiver right now with CMS. We're concerned whether it will get in place in time, and we could end up having a cliff. And so what we're asking for is, in the event we're not able to get something else in place, is to have monies available so that we don't have a cliff and we have some time to get something in place. That being said, to the extent that we didn't use it, it certainly would lapse. I just want to make that clear.
Okay. So with all of that in place before the committee, I still come back to my concern. I've always felt this was probably a pretty good idea, and it was compassionate and it solved the problem. But I have always wondered, because I'm a cynical individual, has anyone conducted the due diligence to ensure fraud protection is built into the program and that we're actively avoiding fraud in this program? Because it just seems susceptible to the potential for fraud. Could you talk to us about that?
Yes. I think in terms of the amount of care that's allowed to be provided, that's established in advance with a prior authorization. That in some instances here, families are entitled to private duty nurse, a full registered nurse, but there isn't a workforce to be able to provide that. Family members can fill in for some of it, the non board of nursing approved levels of service where you don't have to be licensed. So the families are getting less than what they're, if you will, been assessed to need and what they're technically entitled to. So I guess in terms of there's no more than 50% of what is determined as necessary can be provided by the family in terms of compensation. Second level is before someone can take on this role, they have to be screened as any other provider. We use Granite State Independent Living to, if you will, onboard them like any other LNA who might provide the services, as an example. And they're monitoring, to make sure that the hours are documented and whatever, and that what we're paying for has actually been delivered. But I think we do have appropriate controls here. It's not just you can decide to do what you want to do as much as you want. There's specific limits set in advance.
Has this program ever been audited?
Well, it hasn't been audited in a formal sense yet, but it's under our managed care structure, and so that the MCOs, in terms of processing claims, have whatever they would ordinarily do. We certainly will, look at this demonstration, if you will, and again, my concern is what happens if we just sort of let go with no, end up having a cliff here in terms of what happens to these situations. Because some people have been put in a position where a child's needs can't be met, so they've, maybe stopped working so that their child's needs are met. And then, so if we take that away, they both don't have employment and they're not getting, and I think we could end up with some concerns in terms of what the state's position in terms of adequacy of care here.
Question?
Yes, of Mr. Littman. How many families are using this at this time? Do you know?
In the state plan side of it, I think we're talking under 100 families.
Any other questions? Okay.
Mr. Chairman?
Representative Walls.
I seem to remember reading in the newspaper about some families who had their care cut off. They were not being paid by the states, and they ended up staying home to care for their disabled family member and ended up having to go on public assistance. Are you aware of those kinds of cases out there?
Thank you for the question. I don't have those press accounts, but what you described is likely could happen, I think is the case, because, given the choice of, an example of a child who may need to maybe have a trach and need to have, regular care or something like that with disabilities, that they're not in a position where they can do nothing. And so that they could end up where you described for sure.
Mr. Ripple, question for you. On page 7, line 3, there is hereby appropriated to DHHS 700,000. I'm not seeing the word lapsing or non-lapsing, so that means that the default is that these are lapsing funds?
That's correct.
Okay. All right. So, are there any more questions? Go ahead, Representative Woolner.
Well, I did want to ask Mr. Littman. So, if a family did lose this reimbursement and they had to make the decision that they would have to have their family member go into a facility that the state would then be responsible for. So what is the range of costs for those kinds of facilities?
You're talking numbers that, are more than what it costs for a nursing home stay for an individual, if, depending on, like a child that I described that is, a trach dependent and, high medical needs. I don't know that it would reach 700,000 based on the number that would do there, but, there's also, I think, in terms of exposure from a legal standpoint, in terms of not meeting needs in the least restrictive environment.
Representative Burf.
So can you explain what was happening prior to the state of emergency?
So I think in terms of the workforce situation, in terms of number of LNAs that left the workforce or went to different spots, I mean, we lost somewhere, I think it was reported in the Union Leader, like 1,500 LNAs dropped out of the workforce in terms of providing services. So I think concomitant with the public health emergency, COVID situation, what have you, that um, there wasn't, there was always some challenge, but it became a major challenge in terms of meeting needs. And I think as it is today, we're kind of on the edge, and I'm concerned about getting pushed over the edge, honestly.
Okay, so I personally am predisposed to approving this, but I would like to take a straw vote, and I'm going to ask it the same way. If you're in favor of leaving section 22 and SB 430 as is, raise your hand.
My recollection is that we've always done this to some extent.
All right, so we probably don't really have any action on this because we're at some point going to vote on 430, but as a whole. But we've removed the concerns around 22. Do you have a preference of which one you want to talk about next? We're going to move to item 55. 55 is on page 15, midway down. Do you want to start us off? Do you want the department to talk about this? How do you want to proceed?
Well, basically, just, the department come up. It's basically, this is increasing Medicaid reimbursement rates for birthing services. And it seems to me this is the kind of thing we would do in the budget year next year.
Yeah, and that's true. I'd like to hear about that. And I'd also want to hear about this 25% figure, because that, at first glance, that seems like a very hefty percentage. And then you give yourself the flexibility to give different rates based on different geography. And I'm just curious what the methodology and thoughts would be there. So you go for it.
Again, for the record, Henry Litton, Medicaid Director. This bill was originally Senate Bill 401, proposed by Senator Bradley. And Senate Bill 401, the Senate used that for, in finance, changed that bill to be the property tax relief bill in terms of some bridges, roads, and this is where they ended up putting this component. And frankly, where we are with obstetric services in the state is we did not budget for this in because we had the rate increases in 20 and 21, the 3.1% increases, but just the base in which a birth is paid for is off a base that's around $2,000. So 25% on $2,000 is what we're talking about for a whole inpatient stay, DRG payment. The reason that the department strongly supports this is that we've seen 10 hospital closures of obstetric services. In the North Country in particular, we're left with a very small network that has, during the public health emergency, Gopher had to come through with some money to keep Littleton afloat in terms of maintaining their service. They were ready to drop it as well, as a result of finances. And in terms of what losing like a Littleton or Berlin, in particular, as two examples, would create a major geographic hole in terms of providing services. We're already starting to see with the closures that have already happened, more unplanned out of hospital births. We're concerned that what this proposal does is just it buys us some time to work on a longer term plan, because this isn't going to be enough to do it. And I think what I've talked to the Senate about, Senate finances, the large sums of money we're putting into, for example, rebuilding the mental health system, particularly inpatient capacity, that once you lose this obstetrics capacity, to try to reestablish and it is needed both from not just a healthcare delivery standpoint, but if you talk to the economic development folks in terms of the North Country, as an example, that without a hospital delivering births, you got your demographics are set in a way that they're already tough up there in terms of just being an old population. So I understand why you'd prefer to see it in a budget approach, but I think we'll be coming back in the budget, with hopefully a longer range plan than what this does. This, I think, buys us time so we don't deal with more closures.
Representative Weiler?
As I recall, New Hampshire now has more deaths than births. So we've seen obviously from looking at the demographics in the schools, we're seeing a much smaller number of, and so what percentage would you estimate if it's anything like what we're seeing in the school population? It's like 5% every year less of the births.
So I think we've been in the upper 11,000 total births in the state. I think around 11,700 approximately. We've been around a little bit above 12,000 previously. There was, I think, just an article in the paper today, I think front page of the Monitor, about a concern of a spike in births related to what's people getting back to sort of planning life, if you will. But up in the North Country, in terms of the Medicaid percentages, whereas it's just about 25% of the births statewide are Medicaid, it can approach 40%. And I think even a couple occasions, 50% of the births depend on Medicaid in order to deliver the service, and getting paid, something that is probably less than half of what commercial insurers are paying, in some cases more than 3 times less. I think that those hospitals that are more dependent on Medicaid need a little extra help, and that's why the bill also has that provision that you asked about, Representative Edwards, which is the commissioner to be able to target some of this funding so that those that are most vulnerable, but would have a base amount so that all the remaining hospitals are able to continue. I think that base amount was 20%, and because there's a relatively small amount of births in the rural hospitals, there's enough to do that, plus to give an extra amount to the North Country, and also there's the western part of the state too.
Okay, so just generally, my concern anytime there's discretion is that it be applied in a transparent and fair manner, but that's for all of these sorts of things. Was it your testimony that a normal newborn, the Medicaid reimbursement rate right now is about $2,000 per delivery?
Yes, for a normal.
I don't know how they do it for anywhere near that. And then so obviously if there's an ICU incident, that's got to be more. And so Medicaid's probably cutting corners there too on the NICU.
Yeah, I think we've done a lot recently to buttress mental health, including for involuntary admissions. Our reimbursement has gone significantly up. What I think, today what we're faced with, if we don't do something, we're so low that we end up creating something much more expensive for us to deal with down the line here.
So is 25% enough?
I think it's enough to buy us some time because there are some things that I think are going on in the state in terms of studies of how maybe delivery models could evolve. And, I think it's our intent to work with the greater community that's delivering babies to look at what the options are, because it's not just money, it's also workforce and making sure that, there's enough workforce and backup available. And so I think we do need this preferentially now to avoid further closure, and then to look at a more comprehensive plan. And I really do think that the North Country, seen some benefit of the pandemic, if you will, in terms of increasing the number of people that are in the community that are of lower ages, balancing the demographics. And I think if you had Taylor Coswell here, he would support that strongly. But I'll leave it at that.
Okay, so how about midwives? Does midwifery get any increase as a result of this?
So Senate Bill 408 in terms of birthing centers provides for
No, I'm just talking
Yeah.
about what's in 430.
in 430. No, this is just specifically for the institutional services in the hospital.
Is that an oversight? Should we add midwifery?
I think that in many instances, I think that we probably, when we come back, we need to look at the professional side of things, the obstetrician and the midwifery.
So this is just the technical side, not the professional side. Okay.
In many cases, that now providers are part of hospital systems through employment or some other contract. I do think that the whole system of caring for newborns and
I don't mean to cut you off. It's just we
Mm-hmm.
got a lot of roads still to go. Mr. Ripple, I'm reading line 29 about the sum of 2.4 million, and similar to the last phrasing, this looks like these funds lapse.
Yes, they would.
Okay, so with that, I would just say to the committee, do you have any questions? Anyone have any questions? Okay, so I'm predisposed to supporting this. Is there any discussion around that? Because I'd like to take a straw vote if there's no further discussion.
2.5 million.
It was 2.4. Yes, sir. Okay, so same thing. If you're in favor of leaving this section alone in 430 without modification, please raise your hand. Okay, that looks unanimous. So we can skip over this then. Thank you very much. Now, do you think you're ready for 6?
I am.
Okay, so we're going to go back in time to page 3. Go ahead.
Thank you, Mr. Chair. So if I understand this section correctly, it's essentially eliminating an annual report, and I had to read kind of deeply to get into this, on expanded Medicaid family planning services, which was being provided to the fiscal committee. Now, I have not been on that committee very long, so I haven't seen it. But I actually would be interested in seeing such a report on an annual basis. So I would suggest deleting this section so that, in fact, we would get an annual report on the expanded Medicaid family planning services to the fiscal committee.
So as I understand your point, on line 23, where there's a strike through of the words "and annually thereafter," making this, no longer an annual report, you would not want those words stricken so that we would maintain this as an annual report.
I believe that's right. I believe that's what's necessary to achieve the goal.
Okay, so I have a question on earlier in line 12. 2013 is referenced, July 1, 2013. I just wanted to make sure that wasn't a typo. Was it really 213 and not 223 or something?
John Williams, Director of Legislative Affairs. And as you correctly point out, that's an existing law. This actually came from legislation from 2013. And part of our efforts here to clean up outdated reporting requirements, this request was made by Director Tilley from the Division for Public Health. We wanted to tread lightly. We understood the importance of the remainder, but we just wanted to remove the annual reporting requirement since we've been fulfilling that since the 2013 date.
Okay, Mr. Williams. I've been around and I've not actually seen this report that I recall, and I think as much we fully funded the governor's family planning services, and I suspect we'll continue to do that. But it would really be great to actually get reports. So I personally am in favor of striking through the strike through so that we can keep the annual report.
And Representative Edwards, if I could respond just from a drafting standpoint, if that's the goal to keep existing law, then you'd be much better off directing Mr. Ripple to just removing this section from the bill, because this represents existing law.
All right. So on the issue of deleting the annual reporting requirement, does anyone on the committee seem to want to get rid of the annual reporting requirement, or would you like to see what we're doing to deliver family services, planning services.
I would like to see it come to some agency or some committee, because I've never seen it. Normally, these reports come to fiscal, never seen one.
And I've been on HHS oversight, so I haven't seen it there either. But so let's do a straw poll, because I'm not getting this complete sense. But I would like to maintain the requirement to keep an annual report, and it sounds like the smartest way to do that is just delete this section, because really the only thing it does is delete the 3 words "and annually" thereafter. So do you guys want to talk about it amongst yourself first, or do you want to just go for a straw vote? Okay, so again, we're going to do 2 votes. First one will be, in this case, are you in favor of deleting lines 11 through 24 with the, I'm sorry, 11, line 11 through line 24? Oh, you're right. It starts at line 9. 9 through 24. So I'm proposing that we delete that so that we maintain the annual requirement. Or if you are in favor of deleting that section so that the report remains annual, you'll raise your hand. I see everyone. Okay, so that's unanimous. So Mr. Ripple, can you make that happen?
Yes.
Thank you. So I think we've talked about the 4 sections of concern in 430. And so if that is the case, and I'll let you confirm it, but what I would like to do, though, is, because this is just so thick, there's so many issues here, is give everyone an opportunity to come back tomorrow, and we can still pick out a section if you got an issue with it. So consider this an all-you-can-eat buffet still. With that, I think I'm ready to close 430. Mr. Ripple, what do you think we've done on 430?
So I have 2 amendments so far. One is you would accept Amendment 1743H, however, you would remove the non-lapsing sentence to make it lapsing instead. And also you would remove Section 6.
Thank you. That's the way I understood it. All right. So with that, we can move on to 444. This is relative to the Childhood Adverse Experiences Treatment and Prevention. And this is Representative Walls has caught my eye, because this is another pilot program kind of deal. And my working assumption, until I hear otherwise, is pilot projects need a lot of planning for them to be effective. And I'd like to hear about the planning. Senator Whitley, welcome back. What do you want to tell us?
Thank you, Mr. Chair. I appreciate the opportunity to talk about this bill. So admittedly, this is a bit of a dense bill. There are a number of programs and sort of clarifications in here, but the overall purpose of the bill is to fill in a gap in our existing children's system of care. So this legislature has done a whole lot of work building the children's system of care for children with mental health and also trauma. And so, but there is a big gap in services for young children, 0 to 5. And so this bill looks at the prevention side of the program. Oftentimes we get families and children when they are already in crisis, when they are in emergency rooms, when they are in out-of-state facilities. And I am often asked, well, how do we get these families before they get to crisis, when they are most expensive? And this is the way that we do it. We focus on the prevention side. So this is a really missing piece of that puzzle. And it also recognizes that the impact of trauma on young children is very significant. Children are, of course, very vulnerable to the impacts of trauma, both in how vulnerable they are just as young children, but also how it impacts their brain. But the good news on that is that their brains are very plastic. They are able to, there's interventions that we can do to mitigate the impacts of trauma. So that's what this bill attempts to do. So I'm happy to go through the various parts and answer your questions as we go. What would you like to do?
So first, I just want to ask you a couple simple questions.
Sure.
Okay. So the cornerstone of a 0 to 5 age group dealing with prevention, the target population for education are really the parents, right? So we're this program at its core is intended to educate parents to not abuse their children in some way, and to avoid the ACEs happening in the first place.
Yes, sir. So you are absolutely correct that we need to make sure to support young children, we need to support and educate families. I think to get exactly to what you're talking about, if you look at section 9, is the ARPA appropriation for family resources centers. We already have a robust regional structure of family resource centers. They have received federal money in the past that we need to leverage, but we need those resource centers to have what they need to support families to prevent child abuse and neglect. It's called primary prevention.
So you have a lot of interesting people in the Senate. So you've probably heard somebody raise the issue of, is it appropriate for the government to be intervening with parents to parent them on how to parent? Is that an appropriate role of government? Have you heard that general question, and how would you answer it?
We actually didn't get that question in the Senate. I mean, I think here all these are voluntary. We're not forcing parents to get interventions. These are just, interventions that are available should families need the support. So there's nothing mandatory about this. I think that's not something I believe the Senate would support at this point, but these are the supports that should be available and the treatment that should be available if a family and child needs it.
Thank you for that. What is your reasoning, or how would you argue on why this shouldn't just be incorporated in the next budget?
Well, because children are in crisis right now. We have children that are, the pandemic has exacerbated a lot of things, including the children's mental health crisis. We have children in crisis right now. We can't wait any longer. And we do know, I mean, this is one of the most horrific things that I have heard recently. During the pandemic, we have seen an increase in child sex abuse for this age group. So this is a crisis that we can't really, I know it's horrific, we can't really hold off on. The other piece to is it, Mr. Chair, is that we have the dollars available right now through ARPA dollars, the ARPA discretionary dollars. So there are no federal funds. There are no, state funds appropriated. So I'm sorry, if you look at the fiscal note, it is incorrect at this point. There are 4 appropriations listed in the fiscal note, but on the Senate floor, we took out 2 of those. So the only remaining appropriations are number 2, 700,000, and number 4, 1 million. So the other 2 appropriations are gone, and the remaining appropriations are strictly ARPA dollars.
So Mr. Ripple, are you aware of a update to the fiscal note in works?
I haven't yet updated that one, but I can take a look and see if I can provide an update for tomorrow.
Do you agree with Senator Whitley's observation, though?
I do, yes.
All right. So I'm going to come to Representative Urf in just a second. I got one more question
Sure.
for you. You just mentioned something heinous, that 0 to 5 sexual abuse.
Mm-hmm.
And we're talking about a voluntary program, and I'm just curious if we think that the depravity of a perpetrator in this situation is just beyond anything we can do on a voluntary basis. I mean, I understand for everything else, this is maybe a good program, but I don't know if we're setting as an objective to, or how we would even go about trying to remediate such a horrible problem.
Yeah, yes. So in New Hampshire, you may know that we have both a voluntary, and if there's a finding of abuse and neglect, then that's a whole different track for parents. And, the director of DCYF can speak to that. So we have that when there is a finding, that will be some sort of mandatory things involved. And then we have a voluntary system. In terms of the impacts of child sex abuse, so part of this, the one of the remaining appropriations is to expand the workforce for child parent psychotherapy. That's an intervention for young children to mitigate the impacts of horrific trauma that we were just talking about. So I think it is imperative that these children that have been impacted by this horrific trauma get the treatment that they need to grow up into healthy adults. So this is what we're talking about here.
It just seems that the treatment plan would be to arrest and imprison the perpetrator, but
Well,
but
yeah,
anyways,
yeah.
I don't want to get into
Yeah.
all that. I do want to give Representative Erf an opportunity to ask his question.
So just one question. Given these are all ARPA funds, couldn't this just come through fiscal?
Thank you for the question. There are some portions that did go through fiscal. For example, there's a pilot program in here that the department has been working on, and the authority is in this language, and they did go through fiscal, but these are the remaining portions that have not gone through fiscal, and there isn't really a plan to do so. I don't want to misspeak about that.
Again, for the record, Rebecca Ross, Director of the Bureau for Children's Behavioral Health. That's correct. We did have a fiscal item that was approved in November of last year for 1.6 million for the 0 to 5 population. These are additional programs that were not included in that and would codify some portions of this permanently as part of the system of care.
So that's the reason it didn't go through fiscal, because there's policy stuff in here that would become part of the system of care.
Correct.
Thank you.
I agree.
Are there any other questions? So these funds, these are ARPA funds. So is there a use it or lose it aspect to this? How long do we have to spend these?
That is a good question. So the dollars that we're talking about here are not sort of designated ARPA dollars. They're ARPA discretionary dollars. And maybe Mr. Ripple can answer that question. I don't know when our official requirement to spend is. Do you know?
I actually don't know that one off the top of my head. I'd have to check on it.
All right. So it's really just a cautionary note to the department to make sure that they get the program, the funds obligated before they run out. But okay. So are there any other questions? I think I'm generally predisposed to this unless somebody tells me I'm not, but I think I am. I'm ready for a straw vote. Are you all ready for a straw vote? Yeah. Okay. So if you're in favor of OTP on SB 444, you'll raise your hand. I don't see anybody in opposition. So I would like, with your permission, Representative Wallner, I'd like to go ahead and have the clerk call a roll call on this. Are you okay with that?
Yep, I'm fine.
So I'd move, well, I'll let somebody else.
We're going to need a motion in a second. Yeah.
Representative Wallner do that.
Yeah. Yeah. You can motion this one, is what Irf is saying.
Second.
All right. Moved and seconded. Any further discussion on Representative Wallner? No. Is there any more discussion on Senate Bill 444? Representative Walls?
I just looked up for you. ARPA funds must be spent by December 31st, 2026.
Oh, okay. Super. Thank you. The clerk, when you're ready, you can call a roll.
Motion is ought to pass on Senate Bill 444. Representative Erf.
Yes.
Representative Weiler votes yes. Representative Bean. Yes. Representative Wallner. Yes. Representative Long.
Yes.
Representative Walls.
Yes.
Chairman Edwards.
Yes.
Vote is 7-0.
Vote of 7-0. Division 3 will recommend to the Finance Committee that they OTP, and Representative Wallner will write the committee report. All right. Thank you. Okay, so that brings us down to the final two, but these final two are rather significant. So I would like to put us into recess for about 5-10 minutes so that everyone can stretch their legs and kind of re-ready themselves to go through this. So I have the time now, 2:50. Let's get started no later than 3 o'clock, please.
Mr. Chairman. Mr. Chairman. You might want to know that the efficient Mr. Ripple just sent us information on 416. I just saw it in my email.
Oh, really? Okay.
unless we can get started sooner. $4.58. So Mr. Ripple, you do not have an amendment for 458, right? So we're
I do
just going to
not.
use my discussion draft?
Okay, which I did not print out copies of that for the members. Okay.
So I have 3 o'clock. Is everyone ready to get started? I probably ought to wait for Mr. Ripple. He's probably secretly the most important person in the room. So I've given you a discussion draft on 458. By that, I mean, I went through there and I made some markups to stimulate some conversation. So, Mr. Ribson, I'd like you to sit at the table, so if we have questions that come up, but because the committee talked about 458 last Friday, and we have this discussion draft to walk through, I think the role I'd like you to be prepared to play is to follow along with us, and then if we have an issue that we want to take a sidetrack on, have you get engaged. Do you? But I want to respect. Do you want any preparatory remarks before we start driving through this? For the committee, I want to end by 5. Why do I want to end by 5? Because Janet Clayman needs to leave, and so we'd like to get all our paperwork into Janet. So, okay. So, 458, an act relative to the Sununu Youth Services Center and operation of a replacement secure facility. The first topic that we come through, if we just go chronologically, is that I took the Senate's past version and have begun to amend the version passed by the Senate. I skipped over, and this is a little bit rude probably, I skipped over the version that got passed out of the policy committee and out of the House. Why did I do that? I did that because I had a sidebar with the governor who said to me that he really liked the Senate version and that he could see himself signing the Senate version. So I have tacked towards the Senate version and then identified some things where I know we're at odds, that will be at odds with the policy committee. How bad is that? Well, I don't know if you listened to the executive session on 458 in Children and Family Law, but the chairman of the committee basically said that I don't want to mischaracterize it, so I won't. So this is not meant to be anything like a quote, but my interpretation of what she said was, we're going to do things like reduce the capacity down to 6, and then if finance thinks differently, they can negotiate it up. Okay, and so I also heard from you were there. Is that a fair summary? It is. Okay. So then the other big thing the House did was they inserted a lot of language from HB 254. 254 passed the House, went over to the Senate. The Senate, as I understand, has gotten themselves in a position to adopt or to pass SB 254 with what has been characterized as some minor amendments. And those minor amendments, if nothing else, addressed concerns that were expressed that if there was no consequence for property crime possible, that we would be inviting property crime, such as the smash and grab types of things that we're seeing. I don't think there's any intent to start taking kids who have participated in property crimes and willy-nilly put them in the Sununu Center. No, it's just a fallback, I think. And our judges, if we look at the data, our judges have done a pretty good job, along with the legislature, of reducing the census over the last few years. From 2019 to 2020, there's been an obvious trend down to where we see a lot of 11s and 10s towards the right side. So that's a daily census. So that's kind of a background. That's me trying to tee this up. So the first issue that gets addressed is the bed capacity. The Committee on Children and Family Law wanted to go to 6 instead of the 18 that was in HB2. It did not appear from watching the executive session on the bill that there was any data behind it. It seemed as though it was a hope and a prayer kind of number. Representative Woolner, you and I had a chance to talk briefly this weekend, and I think you have something you may want to say on whether 6, 12, 18, or some other number is right to you.
Well, I do think that, we've done a lot in the last several years to reduce the number of children that are housed at the Sununu Center. And I think there's still a few things that we can do to continue reducing it. I do think it's interesting that what we were handed out to right just now looks different than what I got in my email. Because when I got it in my email today, I got something where it was divided by detained and committed. And so when I look at those numbers, I think this is something where it's all been lumped together. So it makes the numbers somewhat larger. Also, I do pay attention to the dashboard that we get monthly. And I need to go find my my March dashboard. But I thought in the month of February, the dashboard actually said we were at 8 children. So I just wonder what the discrepancies are with this piece that we just got and what we received in our email.
So what you received in your email is a Excel file that has 3 tabs on it. The first tab is the daily count of every single day from January 1, 2019 through today, and it's a list that has male, female, detained, committed. The second tab is this chart, which is just a chart format of the average daily census of each of those months. So if you took all of those days and averaged them out, this chart shows that. The third tab on that Excel spreadsheet has the same data, but just listed in a spreadsheet form rather than in a chart. And I'm not sure, to answer your second question, I'm certain that there were not only 8 youth at SYSC in February, so I'm not sure what that is.
I'll have to look again and see. It could just have been a typo, so who knows. Can I have another?
Yes, Paul, go ahead.
So I guess for our deliberations here today, I would like to, and I guess everybody must have gotten it in their email, the charts that were separated. I guess what I would like to take a look at are the number of committed children as opposed to committed and detained. It seems like that sort of inflates the number.
Can I turn that into a specific question? So for example, on December 1st of 2020, it shows a total daily population of 10. Can you tell us what the committed versus detained were in that month?
So again, the spreadsheet that I sent out had 1 page with every single day. So December 1st, 2020, there were, let me just pull this apart so I can see the header.
So I think you're just going to have to eyeball it and give us an
December
estimate.
1st, 2020, there were 4 detained females, 0 detained males, so a total of 4 detained on December 1st, 2020. And there were a total of, let me see, I'm trying to make sure I have this lined up right on the printout, sorry.
We're asking you to compare apples and oranges, though, because you have daily information and we have an average of a month in front
Yeah,
of
and
us.
you have the daily too. It was in the spreadsheet that I sent you.
Okay.
I sent both the daily and the monthly averages. I'm sorry, I had that wrong. December 2020, total detained was 4. There were 0 female detained, 4 male detained. Total committed was 5. There was 1 female committed and 4 male committed on that date.
Total commitment was?
On that date, total committed 5 on December 1,
Okay.
2020.
All right.
1 female.
On that date, on that one date.
Right. So it varies. So do you have a follow-up?
No, I just wanted to point out that there are two categories, and I believe this chart sort of lumps everyone together. And I think we need to look at
So let me ask you a question about that.
more in-depth.
Is it your thought that we could reduce the population at Sununu more by simply having a different place for detained versus committed?
I think that would be a possibility by using providers that we're already using.
So the way that SYC currently operates and the way that we anticipate a future state operating is we no longer programmatically distinguish between detained and committed kids because the numbers have gotten so small. Once upon a time, there was a detained unit separate from the rest of the committed facility. As the numbers got so small, it became silly because sometimes you'd have one kid in a detained unit and you'd have, so we got to the point where we started mixing kids by gender and by programmatic need rather than by detention or commitment status. Just made much more sense operationally because you condense the kids in a way that you could, have sensible or at least something approaching sensible staffing. The idea of moving detained kids out, I think, could be challenging. You still need a fully secured facility for detained kids. A lot of times the detained kids are actually even more unstable and difficult to work with than the committed kids, although it varies because we have kids that come in with all types of needs and offenses. So you could do that, but I don't know that while it might reduce the size of that facility, you would then need a separate facility that you were paying somebody else to run or that the state was running.
So the approach, and there's no legislation now telling you to segregate detained from committed, and therefore, at this point, if we're using existing legislation, it is an aggregate number, right?
That's correct.
Okay. So, so the first thing I did was where in the Senate bill it said 18 beds, I added that the facility is at least 14 beds, but no more than 18. And then I direct that the Commissioner DHHS shall conduct a data analysis to determine the bed capacity to be used for future architectural designs using past census trends and expected census impacts of current legislation, and to do that no later than July 31 of this year. The department will prioritize locating the, well, we'll stop there because that's really the point of that is to say, rather than make this a legislative effort to just grab a number, I would hope that we would agree that data analysis is the appropriate way to set the capacity, and that we can trust and defer to the commissioner the process of doing a data analysis to pick the number. I think we're kind of around the same ballpark. 18 was an HB2. Maybe this data suggests it doesn't need to be as much as 18, except for the fact that you never know when you're going to get a weird surge. You're never going to know when you're going to need to have a unique division of male, female, and separations due to things like gang status and the like. So some surge capacity does seem to make sense above just a hard number. But I'm comfortable delegating to the professionals the actual size between that range. Do you guys want to talk about that? What do you think? Representative Long?
Thank you, Mr. Chairman. With respect to Senate Bill 254, now we know there's a couple of areas that are problematic. Would some of that language decrease detained?
I am not comfortable predicting that that's going to necessarily decrease the census, and for the reasons I spoke about last time, because what the original version of 254, prior to the one that passed the House, retains something that's in current law, which is 3 lesser crimes could still have a child go to SYSC, and that's actually the way that most kids who go to SYSC end up there after multiple charges, not after a first offense. The way that 254 changed that in one of the amendments in the current version that's over in the Senate was it eliminated that kind of pathway, but added in a new pathway based on community safety and community risk, which as a policy, I don't necessarily think is a bad shift, but I'm not able to predict that that's going to result in less kids in the facility. And I think, it's risky to assume that that's going to result in less kids in the facility. I don't know that it will. And it could result in more kids. I mean, I don't know how that's going to play out compared to the current pathway.
That's fair. Thank you.
Representative Weiler.
Thank you, Mr. Chair. About detained. So the ones that are not detained, can we assume that they've been bailed?
No, there's not bail in the juvenile system. When kids are detained, typically they go in for, it could even be a couple days while things are sorted out, or it could be weeks while things are sorted out. Or if there's complexities, they could be in detained status for, I've seen kids in this ordinary detained status for 3 or 4 months while they're waiting for certification processes and things like that, and even longer. And when kids go in as adults, we categorize them as detained. So when kids go in because they've been charged and found guilty of an adult level offense, and they remain with us until they turn 18 in that instance, those all fall into the detained category. The commitment category is following adjudication, when a determination is made that the youth committed whatever offense. And the way that law currently works, most offenses result in what is a 3-month time in a commitment status, followed by a parole hearing, at which point most of the young people do get out after 3 months committed status, and then we'll move on to whether it's back home or residential program or some other option. And then some of the more serious offenses could be a 6-month prior to parole.
Yeah, because the lawyers are defending and delaying and all that sort of thing. But so this is unusual to have these few in detain, I guess.
Yeah, what's really interesting is, and if you look at that day-by-day data and really did analysis, you would see there was a period where we had more detained kids than committed kids.
Yep.
But now we've seen that kind of flip back again, not by a lot, a couple more committed, a couple more detained, but it's if you look at the historical data going back 20 years, you're seeing 120 committed kids and 20 detained kids. And now we're seeing about ballpark 6 and 6, 5 and 5.
Unpredictable.
So I would imagine that financial disclosure that you hear sometimes about past performance is not indicative of the future performance. That applies here too, right? I mean, we can do a great data analysis, but it's sort of difficult to foresee how well that trend will hold up in the long term. And we're building a facility for what, 20, 30 years at least?
I'd imagine so.
Okay. So, so I don't want to call anyone out by name, but I've heard a member of this committee say that the bed count should be 6. Does anyone want to talk about the number 6?
If mine's the name you want to call out, feel free. I'm glad to speak to it. I've told you I don't support your amendment.
That's fine. I have time to find another vice chair. Representative Wallner?
Could I ask Representative Mr. Ripson another question? So could you tell me how many group home beds you are contracted for at this point?
Rebecca Ross could probably give the exact number, but it's probably 400 or so around the state.
Have any idea how many children are in those beds?
I think point in time data is probably somewhere around 300 and change right now.
And do I understand that maybe within the last year and a half or so, we went to Governor Council with contracts, and that we've changed our way of paying? We don't pay any longer per day. We now pay by contract. So you're contracting for a certain number of beds at a facility. Is that right?
Not quite. So we did shift to a contracted model for the first time about a little over a year ago, or in some instances a little less than a year ago. Those contracts were finalized. The reasoning for that was, prior to that, all these providers were basically operating on, they had to meet minimum basic Medicaid rule standards, and that was kind of the extent of how we were able to derive what it was we wanted from these providers. And we wanted a lot more than what we were getting. So we created different levels of care with different intensities, different requirements such as becoming accredited programs, utilizing models such as 6 core strategies to reduce restraint and seclusion, etc. And we entered into a contract with the providers for that purpose, put it out for a public bid, everything else. The contracts still do set a daily rate, however. So they still do get paid on a daily rate basis for the kids that they're serving. But the rates through those contracts were enhanced to actually match what we were asking them to do, as opposed to the historical model, which people had their rates set once and then they were stuck stagnant for, in some instances, 12, 13 years.
Yeah, okay. Just one more question. Okay. So we have the capacity of 400 beds. We're probably around 300 at any one time.
Yeah, there's probably about that many under contract, with about 300 or so that are currently filled. I would be careful to say capacity, because one of the challenges we've been seeing really since the start of COVID, but for different reasons, is providers not being able to actually have the amount of available beds that they are required to under their contracts. Initially because of separation rules that they had under COVID, currently has much more to do with workforce capacity and not feeling they can safely operate to the full capacity of their contract.
So we could say, I mean, I'm sure that of those 100 beds that aren't that are not filled at any one time, it might be hard to fill all of those. I mean, it might be hard to get the group homes to be able to take all of those because of staffing and a number of different things. But there is some capacity in group homes at this point, I assume.
I think there's wait lists at most of them, but yes, on paper there's capacity. Whether there's, actual availability today to take a child. I think the big distinguishing point that I would make, though, is that right, we don't maintain discretion over whether a child is detained and committed. That's a court's decision as to whether a child's detained or committed or put into residential care. What we do have the authority to do, and which we do regularly, is if a child comes to us committed, we do have the authority to administratively release a child to a residential program if we think the residential program is better suited, and we do that pretty regularly. So we often do see kids move from these facilities, from SYSC onto residential programs, but in the first instance, we're not the deciding body. A court's the deciding body as to where that child is going to go. I think, I'll leave it at that.
Okay, thank you.
So these census numbers, in other words, reflect those that you kept and do not include those that you moved into an alternative group home.
Correct. Yeah, there's no,
right.
these are the numbers of the kids that are actually in the building, excluding the kids under the Vermont contract. They're not included in these numbers.
Thank you. So this is really to the committee, and it's kind of a two-part question. Are you comfortable delegating to the commissioner the authority to do the quantitative or the data analysis to establish a bed capacity? And if you are you comfortable with this range of selecting between 14 and 18? Would you prefer 12 to 20? Would I picked 14 to 18 based on sitting in my comfy chair typing. So I'm open to some conversation there.
I'm listening to the director, and I think he's got, the numbers in his head every day, more than any of the rest of us could come up with. And I think from his testimony, he's comfortable.
So part A of that is you're comfortable delegating to the commissioner the authority to pick the final number?
I am.
Do you, part B, do you think the 14 to 18 range gives the commissioner enough flexibility, or would you prefer a different set of numbers?
I'm hopeful it could go less than 14, but if it goes higher, what are we going to do? And I'd also like us to look at the option of using more of the private group homes and having some of them maybe come up to I guess it's stage 4 level of security.
Okay, so Mr. Ripple, at this point, what I would do before this became an amendment, there's so much more to it than this, but just the beginning, is to change the 14 to 12.
Okay.
Okay. I'm not hearing anyone say no to delegating to the commissioner.
I certainly respect Mr. Ripson's information, but I think really it's the legislature right now that's making the decision.
What number would you select?
I would select 6.
Representative Walls? Representative Long, you have an informal voting going on over there. What do you think about delegation to the commissioner and what the number should be?
Yeah, I mean, I did support the 6 in the policy committee. It may be a dream. I mean, the more I listen to Mr. Ripson, the more I see that my 6 may not be the correct number. But I just want to be assured that we're doing everything that we can to be sure that if there's a program in a community or a service somewhere else, that child gets that service and not be detained.
Since you were in children and family law, was the number 6 derived from a data analysis perspective, or was that a number that was perhaps aspirational as opposed to data-based?
I mean, I can only speak for myself, and it was aspirational for me.
All right, thank you. Representative Irf?
At this point, I do still support the 6.
Mr. Chairman,
Representative Walls, yes.
so this has been worked on multiple terms, multiple years, and these numbers have been examined. There have been the number of the appropriate number of beds has been studied with multiple advocacy groups, the department. A lot of people have looked at this over a long time. This is not something that is aspirational. This is based on data. And, the Disability Rights Center, Legal Services, who we heard from before, Michelle Rangren, other people have been involved in this and setting this up. And I feel like we're kind of sitting here right now, shooting by the seat of our pants, really just relying on the testimony of Mr. Ripson, when there's been a lot of other information that came in. And it's been a situation where we have seen over and over again there were 2 things that contributed to the large numbers of kids incarcerated at Sununu. One was the size of the facility. If you build it, they'll come. The other one was the laws under which kids could be committed. As we have reduced the crimes for which kids can be committed, we've watched those numbers drop. There's been a whole complex of things that have been going on really since we raised the age of delinquency in 2014. They have really worked hard now. What would that make that? About 8 years of working on this. And, there's a reason we're at 6. It's not just people shooting by the seat of the pants. And I'm concerned that we've got one witness here. We're not hearing from all the people that have worked on this year after year after year, from all the people that have been on the study committees that have come up with these numbers and studied this and determined that this really is a realistic number. And we're doing this here on really very limited information. And that's why I'm staying with 6.
So my understanding is actually the opposite, that all the analysis that we've seen year after year after year, from the Alvarez and Marcel study to what got into HB2, is that in order to give us the flexibility needed, the number was 18. And I'm expressing some interest in entertaining the possibility of a lower number, but 6 is imaginary as far as I'm concerned. That is a total aspirational stab in the dark, and I just am embarrassed at the lack of data analysis that would determine the number 6. We have a public safety responsibility, and I think if we put 6 in there, that is an abdication of our responsibility, and I will not allow 6 to be the number if I have anything I can do about it, because it's just imaginary. There's fiction. So Mr. Ripson's here to represent all the analysis has been done to date. So despite my emotional outburst there, Mr. Ripson, if you had to guess a number right now based on all of your analysis of all this data for over all of these years, and we were projecting for a facility for the next 20 to 30 years, what number would you select?
The number that we continue to support is 18. That's not based on the idea that we expect there to be 18 kids there, but based on the idea, which was written in one of the very early versions of this language, I think back during the budget process, is that we anticipate an average daily census of 12, but that given the need to separate 3 different groups, 2 different groups for male, 1 for female, that you need some excess capacity because you're not going to have an exact number of females in the 2 different groups on any given day. You need some flexibility and spacing. I think that's what the data to date shows, and to the extent that the argument is that there's been a lot of analysis to point to a lower number. When I first got here, people were talking about building a facility for 40, right? That's only 3. I've only been here for 4.5 years at this point. People were talking about building 3 different facilities in the state at 20 apiece. I mean, there are lots of ideas being floated around. And the fact that we've gone from about 75 kids when I arrived in this state to an average of 12, I think is pretty remarkable progress. And when I talk to my colleagues around the country, they're shocked by that progress. But I haven't seen the evidence yet that we're at a place where we can operate with 6. And again, I point back to the reality that DCYF, SYSC does not decide who goes to this facility. Judges decide that. Prosecutors impact that. Public defenders impact that. Certainly we get asked for probation officers' opinions on these cases, but we're not the deciders. We just have to take all comers no matter what. And until I see data that the people who decide these things have us down to operating at 6, I'd be horribly uncomfortable with operating at that number.
Thank you. So we've spent 32 minutes on this particular topic, and it's a critical topic because it's like the number one cost driver of the whole replacement facility, and then it's going to be the cost driver behind the staffing behind it. And so it's really important that the committee pick an approach to this that works, because if we don't pass this bill, there's no plan. The Sununu Center by law has to just shut down at the end of March. There is no continuity of operations without this bill. It would be irresponsible for us to not pass this bill, and we can't pass this bill unless we agree on a number. So what I think I'm going to do is I'm going to put us into a recess for 5 minutes so that we can discuss this in caucus. Okay, we're out of recess for our caucuses, and what we're going to discuss next is Senate Bill 458 as passed by the Policy Committee and as approved by the House. I'll entertain a motion.
I'd move we recommend OTP.
Who seconded? Okay. Is there any discussion? When you're ready, Mr. Clerk, would you please take a roll?
On the motion of ought to pass on Senate Bill 458. Representative Erf.
Yes.
Representative Weiler votes yes. Representative Bean. Representative Wallner. Representative Long.
Yes.
Representative Walls.
Yes.
Chairman Edwards.
No.
6-1.
So with that, the motion carries. Who will write the blurb? There will not be a minority report.
Okay.
Okay, so we're on SB 459. Mr. Ripple, there was no amendment prepared for 459, right? I don't think there was.
There wasn't, no.
Okay. So we have a discussion draft that's available. Could you pass that over? And yours is here. Sure. And so for Harry here. Yeah. We'll wait for Mr. Ripple to return to hand out copies to the audience.
Change health facility to include urgent care and that takes out the ones. I understand got a testimony again today. The two major urgent care facilities and all the hospitals are on board with this. That's one. Take out the personal, and I'm not, I don't, I didn't draft this amendment because it's sort of in that time. To take out, make those personal, no personally, everything I told you.
Okay, so we're going to start talking about SB 459. I had prepared a discussion draft. I think that's my copy. And I sent this out last night. You got a copy of it, Representative Wallner? From last night? Did you see that from last night?
What you just passed up.
Okay. All right. No, I was just trying to make sure that I had provided her a digital copy last night. So, I think I'd like to walk through this and then have some discussion at the appropriate times. The the first thing that that I suggest we do is the definition of workplace violence. I think was so broad it no longer meant workplace violence; it meant something else. So it included verbal abuse, even if the victim had no stress. So that didn't seem to make sense. So tightened up workplace violence so that a normal person would understand the word violence, and then created a new definition for hostile words. Hostile words means aggressive, belligerent verbal abuse in which the recipient reasonably believes that the speaker intends to injure or create excessive stress, or in which the recipient suffers psychological trauma. I'm not wedded to that particular definition, but I am sort of wedded to the concept of breaking workplace violence up into a distinct subsect, because initially it's just so broad it doesn't mean anything. Any comment on that?
I agree.
Representative Walls?
Thank you. So again, you know, I'm not on criminal. I don't do criminal work usually. But often in the law, specific words have developed specific meanings, or specific definitions are out there on specific meanings. And I'm trying to understand where this definition of hostile words came from. Is that a widely accepted definition in
I said I invented it.
RSAs? You invented it?
Yeah, I believe I said that. I wrote that because workplace violence was so inclusive it needed to be broken out. So I wrote the definition of hostile words.
So the question I have is, has this been through legislative services? No. Okay. Well, no. There's
Draft for discussion.
That's great. There's a reason I'm asking that, and that is, you know, I just want to be careful when we're inventing definitions in the law that we're not changing definitions that are out there in another part of the law and inconsistent with it. Because there are words that have come to have meaning, and that meaning is across the board in lots of different crimes or civil actions. And when we invent new words, I just
Out
want
of an interest in time, I agree with you. The purpose of this is to discuss it. And it will need to go through OLS before we have a draft. So I think you're concerned about finding alternative definitions that are already in the law. We can do that when we run this through OLS. As you recall, this bill was voted out on Thursday, and we have no time to really do this the justice it needs. I'd be open to interim study this bill, and then we could have all kinds of times.
I'm not open to interim studying it because I think it's urgent that we protect our healthcare workers. But before we do this, I just was looking to find out if somebody who knows more about criminal law than I do could help me understand if it may be great that you've invented this all out of whole cloth and it may work just fine right here. I'm not saying it doesn't. I'm just saying we need to find out.
How about where I started though? Do you agree with the way the workplace violence was defined in the bill that we received? Workplace violence means any act or threat of physical violence, harassment, intimidation, or other threatening behavior that occurs at a healthcare facility, including verbal abuse, without regard whether the victim sustains an injury, psychological trauma, or stress. If a victim has no stress from words, is that workplace violence?
What jumps at me with my legal mind is some of these things require something called mens rea, which in English it means intent. And was this language an attempt to address a need for intent? I don't know the answer to this, but I look at this with different eyes than you do because of my training, and it just raises questions for me. And I'm not trying to be critical of what you did. I think words are there for a reason. And having gotten this so last minute, I don't know if by taking those words out, we're taking out an element that has unintended consequences. That's all I'm trying to say. I'm not saying I agree or disagree with them. I'm just saying, without knowing the history of how that definition got there and what the intent was of what's the waterfront they were trying to cover with those words, I'm reluctant to change it without having more information. That's all.
Thank you. Is there any other comment on the definitional part? All right.
I think it leaves it so broad that if a nurse walks into a room and the person turns their back on them and ignores them, some might say that's a hostile act. So, you know, it is wide open.
For what it's worth, I agree with your definitions.
Thank you. So then in 2, I'm just looking at it, trying to figure out what I did here. I created a new paragraph 4, and that caused some renumbering. Said health facilities may implement and maintain a workplace violence prevention program. So this gets right at the issue of the financial impact of this policy, is that this has been set up to be mandatory, where the state is directing that these programs take place. And we saw that when it just looked at our 2 hospitals without regard to the third that will be opening if everything goes well. It adds an FTE per facility in order to run these internal programs. So what I did here was basically say that participation in an internal workplace violence program, having one, is not mandated by this program, but it is encouraged. Said program may consider the size and complexity of the health facility and shall address the following topics or others deemed appropriate by the health facility, the goal of which is to encourage participation and address prevention, recognition, response, and reporting of workplace violence. So it maintains the program by including the elements that would have been in the program, but rather than making them mandatory, it makes them suggestive, and it also opens it up so that it can be more, the program could be more than what was described. Is there any comment about just strictly limiting for a second the conversation on voluntary or versus mandatory requirements to have an internal workplace violence program? And before anyone talks, I care deeply about violence in a healthcare workplace. I've worked 43 years in hospitals. I've seen it, and I think healthcare administrators want to preclude this anyways. Go ahead, Representative Walls.
I think changing your first shall to may guts the program. I think it makes it meaningless and it eliminates the protections that this bill is trying to provide to our healthcare workers. I think some of the other mays that you've done, I mean, I kind of went through as much of this as I could read in the time allotted because I didn't see it till right now. Some of the mays are acceptable, but that one in particular, I think that just guts it. And I think if we don't require a facility to have a workplace prevention program, we might as well not even be passing this because they can do this without us. So saying may, that already exists. What we're trying to do here is provide the protection. And the way we're going to provide the protection is to say shall.
Is there any other comment on that?
The nurses lobbyist called me to say that they felt that if it wasn't required, it wouldn't be done. But I see you have language in here to require a report. So if they don't bring in the program, they have to report why, which may put pressure on them to bring in the program, especially if you create a lengthy thing to describe. Why don't you have such a program? And what is your experience if you put that in there to try to explain it, force them to make a decision, I think.
So the totality of it was meant to create a bottoms-up free market of criticism and pressure instead of a top-down directive mandate from a government. And so in a live free or die state, when I heard so much about how everyone wants to do this and everyone cares, it doesn't seem to me like a mandate is necessary. What is needed is guidance and leadership. And that's what I attempted to do with this rewrite. Representative Irf?
Thank you, Mr. Chair. So I agree that it doesn't seem like a mandate is necessary. However, one of the things that we heard the other day had something to do with the legal gymnastics of it, and I can't speak to that directly, but I'm sure there's somebody here who can. But I did speak probably with the same lobbyist that Representative Wallner spoke to regarding how we could get, I think, all the way to what you want, but without removing the word mandate. So in the course of that conversation, I asked, so is everybody, are all the hospitals on board? And I believe the answer we got to that last week was yes. I said, okay, how about all the urgent care centers? No, the two biggest ones are, and the three that are less have fewer than 3 clinics. I don't know if they're not or they haven't responded, but in any case, the suggestion was made to, as is already in the bill later on, relating to the members of the commission The members for the urgent cares, as I recall, come from those with with more than 3 clinics. The suggestion was made to put that same wording up into the definition of healthcare facility. And in fact, I guess I can probably read you the language better if you want to hear the actual language. So, health facility, as it's currently stated with another sentence, the term does not include any non-hospital affiliated urgent care with less than 3 clinics in New Hampshire. So with that, my understanding is there's nobody that would be affected by this that doesn't want to be affected by it, except for the state, perhaps, and I'll come back to that. So that gets rid of the, yes, it's still mandatory, but everybody wants to be in. Give me 1 second to get back to where I was.
I've heard that, but I've actually not seen any documentation to show each facility has said that they want to be in this. I've heard it said, but I've not seen it.
I'll let others speak to that. Let me go through the things I think we need to change, and then you can have people up to speak to that. I can't speak to that myself from personal
All right,
knowledge.
go ahead.
Okay. So as you have suggested, we need to remove all personally identifiable information. Is any disagreement from the reports that are produced? I don't think there's any disagreement about that. Strike the $2,000 fine. And by that, essentially, you're making it voluntary, because if anybody doesn't get involved, they're not going to get fined. What's going to happen? So so that gives you back to your goal of nobody has to be in there if they want to be in there. Include your definitions of workplace violence and hostile words, and then, of course, get hostile words into the proper places in the document. And I have one sample cut at that, which I was going to send to Mr. Ripple later today. Maintain your repeal date. I think it was in 10 years or something. So keep that, whatever it is, so that the program can be looked at, as you suggest, in that time frame and see if it still needs to be in place. And if we all feel it's appropriate, remove state facilities. They apparently have very good programs already, and that would eliminate the cost. And they could be optionally invited to attend.
So
if they
would you
wanted
do
to.
that as you're redefining the definition of health facility?
I mean, where would that
Well, but-
happen?
Yeah.
Sure.
I
I'm
mean,
not sure.
you're talking about how you would limit the size of the urgent care centers, and so we could, in that definition,
Exclude state.
exclude state.
Yeah. Yes, and I actually asked Kevin again. I asked Mr. Ripple about this. This didn't have time to do it today, but the idea would be to not only include NHH and the Glencliff home, obviously also Hampstead would be coming on board, but it should be general enough that any future state facility doesn't have to be involved, and appropriate wording to let them opt in. So I think that's all of the items that would turn it into something closer to what you're looking for without the word mandate. And if I missed anything, perhaps the other folks could speak to it. But I think you could speak to the people here that could give you some confidence about the people that really want to be in this and why they want to be in it. Thank you, Mr. Chair.
So I added into this references to RSA 354A, right to freedom from discrimination in public workplaces, because I think that helps clarify the expectations of behavior towards one another. Do you have an issue with that?
No, sir.
Would you, if we recast this more along the lines that you're suggesting, would you keep the part here on the second page where it says health facilities opting out of participation with the New Hampshire Healthcare Workplace Safety Commission shall submit a written notification within 15 days of the effective date of the legislation, stating their decision to opt out? Would you keep that?
Sure. I mean, are you basically saying if any of the facilities that just want to jump out without being fined, you want this out of them, from them? Is that what you're saying?
I don't know. Does it become superfluous to have them sign a document opting out if your observation's correct and it basically becomes voluntary without any fines anyways?
I guess I will leave it to the rest of the committee. I mean, I have no problem with that being in there. I'll leave it to the rest of the committee to determine if that's.
Representative Weiler, do you have an opinion?
I think,
We're talking about this.
yep. having them submit something in writing, then they can't deny that it's been offered, and then their employees can say, can look at what they offered and say why. Make them explain.
Are there any other comments on this point? Representative Walsh.
Just can you tell me? I'm not exactly sure which paragraph you're talking about.
It's a little hard because this isn't numbered. It turns out to be the second page if you flip it over, and if you go down about 60%, it says renumber from here for healthcare facilities opting out of participation. That section. Basically, I'm saying, you know, if a hospital or one of these covered entities don't want to participate, they would be expected to say so in writing. That is meant to bring public pressure on them so that they would have a bottoms-up approach to wanting to participate without the state coercing it.
So today, when there's a shortage of healthcare workers out there, I agree, healthcare workers are going to be inclined to look at something like this and go, maybe this is not where I want to work. But we're educating healthcare workers like crazy, and maybe in 5 or 10 years, we're going to have a lot of healthcare workers. And I would like to I don't have a problem with mandating this. I think we need to protect workers, period. And I think there are always going to be people willing to work at those facilities that don't have the safety provisions in place. And then they're going to be victimized. They're going to get hurt. Somebody's going to hurt them. I think we should be mandating it. That's just my belief. I just think.
So should we extend the mandate to Home Depot? Do you care equally about all workers, or are we just doing a carve out for healthcare and treating them as a separate part of society?
I think there's OSHA and other things that address Home Depot. I'm just talking about right now healthcare workers. And I'd be interested in hearing what Representative Erf is trying to say.
My comments were related to the existing bill, so there would be a mandate. The modifications I was talking about were to the existing bill, not to Representative Ezra's bills. And then what he was asking was, of the items that are in his proposal, would we keep, for instance, education RSA 354-A:29, et cetera, and would we keep the health facilities? So the idea is that we would stick with the mandate. That was everything I was describing in my conversations with the lobbyists. They were willing to basically change those things, and it was essentially a voluntary mandatory system. I can't remember what the words were they used, but it was actually something like that.
If we have, may I speak? I don't want to be unrecognized. Okay, thank you. I didn't mean to jump the gun. So the idea is to have it be mandatory for private facilities, but voluntary for state facilities. Is that my understanding?
Well, the suggestion was, and again, this came from the lobbyists, if we're concerned about the cost, the only cost in the bill is the state facilities saying they have to have people. So my understanding is the state has pretty good programs in place. So if we, the committee, decide to eliminate the cost, all we have to do is say the state facilities don't have to be part of the mandatory. They can be an exception to the mandatory demand.
So I'm wondering, may I follow up? Yes. So what about if we say state facilities run by the state, but if the state facilities are run by a private entity, then they're subject to this? So that if we're talking about state employees, that's exempt. But if the state has contracted out the running one of these facilities to a private entity, what would you think about then making it mandatory for them?
I don't want any of this mandatory. So I'm already being drugged through the razor wire. Okay. This is not why I got shot at, is to tell hospitals that they have to do a program that is common sense that they ought to do. But okay.
Mr. Chairman, I cannot get over the fact of the story that I was told, as I told you 2 weeks ago, about 2 strangulations at Dartmouth Hitchcock. 2, not 1, but 2. And they still don't have the safety precautions in place to ensure that doesn't happen. I mean, these are serious things that are happening in what's probably the best hospital in the state. And they should have the money and they should have the motivation to protect their workers, and they're not.
let me, for the record, state that I'm opposed to strangulation of anyone. I think that an institution as wealthy and as enlightened as Dartmouth would be all over this, that they don't need the state to do this to them.
But they're not.
Maybe I'm naive. I just think better of people. All right. So let's just to point out what Representative Erf has suggested, and which has changed things, is where on the first page in section 2, where it reads, where I deleted the word shall and inserted may, Erf would like to keep shall and get rid of may. So the shall would remain. And so what we were trying to do is crosswalk the rest of this to see if there are any good components that we ought to keep in the Division 3 amendment.
I'm sorry. I'm a little thick, and I know you just said this, but I want to hear it clearly. So we're looking at line 12, and the shell there. You're suggesting that on page 1, line 12 on the original bill.
Wait, I don't have that in front of me.
Okay,
That
so
shall would
let
stay?
me explain to you what he's doing.
Yeah, because I'm getting a little
Okay.
lost.
Maybe we should start with, did everybody understand what I was doing? That I was starting from the
Yes.
original bill and making those half a dozen changes to try to make it more of a, quote, voluntary system with a mandatory word? Did we get that? Okay. So if you all are on board with that, hopefully, so that's our basis. We're starting from that point. What Representative Edwards is doing is going through his amendment and suggesting pieces of his amendment that would they also be appropriate to be incorporated into the bill as it is.
Thank you.
Does that make sense?
Yeah, I'm just, I was sorry. I was having a hard time following. But thank you. That does help, Keith. Thank you very much.
Go ahead, you're on a roll.
I don't know what other pieces you want to add in. I can discuss those two that we talked about. You want to go through those two, or do you want to keep
Sure,
going? So-
let's just wrap up the two then.
Okay, so he mentioned two right off the bat on the second page. One of the ones he wanted to keep on the second page is the first thing that's, well, the second thing that's heavily bolded. It's about 8 lines down. It has a number 2 in parentheses in front of it. It relates to freedom from discrimination. And I don't personally see a problem with including that in the bill, but if others do, they can suggest that they do. Further down on that same page, where that's what he mentioned earlier, the renumber from here and for that paragraph, he would also like to include in the original bill. I'll let you.
Yeah, and I also want to charge the commissioner of DHHS on staying on top of the eligible members once we get the healthcare facility definition hammered out, and have the commissioner know who's actively in the program, and if people are not, or institutions are not actively involved, that they would be indicated as not being active. Later, I suggest in the bill that they create a website where all this stuff is very transparent, so that there's an opportunity for the public to know who's participating and who is not, and therefore they can put their own bottoms-up pressure on the system. Comment?
Well, I find it very confusing to, on one hand, say that they may implement, that they to keep in they shall implement, and then come over here and have opt out. I mean, maybe there's a different way of saying if a healthcare facility does not abide by this, they have to do a report. But it then opens up for me, oh, well, maybe I can opt out.
Yeah, so I agree with your point. Once we went from may to shall, this shifted this paragraph. So I would just see deleting most of the paragraph, but what I would like to see remain is the commissioner of the DHHS shall follow up so the participant status is proactively known, such that participation status is properly reported in the annual report. So if there is somebody who's covered, who's supposed to be covered by a shall, but isn't coming to any meetings, the commissioner would annotate that in the annual report that XYZ hospital is supposed to be in the program, but never came to a meeting, never provided a report. That's what I'm trying to do there.
So you would take out the opt-out.
I'd take
portion
the
of that.
opt-out out because it
Right.
just doesn't make any sense once it becomes mandatory.
Okay.
Mr. Ripple, have I lost you? Because I
No.
could try harder.
No, I get it. So that last sentence under renumber from here, most of it would be out, but the sentence that begins the commissioner of HHS, that would stay in. And we might have to figure out where exactly in the RSA it would go, but it would be in there somewhere.
Okay, good, thank you. Okay, so then the next one does another shall may. Each health facility may prepare and submit to the Healthcare Workplace Safety Commission an annual report. So in talking to one of the lobbyists, it was suggested to me that the report probably ought to be mandatory, even if we made the development of an internal program optional. And so if we were to honor that feedback, this should just not be changed at all. It should just remain with the shalls. Moving on, the chair of the Joint HHS Oversight Committee, with the advice of the Commission, may recommend updates to New Hampshire statutes or to the rulemaking process led by JLCAR. Basically, what was going on prior to this is that the Commission was going direct to the Commission, the Workplace Violence Commission, was going to the Commissioner of DHHS directly and saying that the Commissioner of DHHS was supposed to promulgate rules with the advice and consent of the members of the commission. And I don't think we want to delegate executive branch action based on the consent of a commission. I think a smart commissioner would listen to the commission and interpret it, but the consent of the commission for the commissioner to act should not be part of this. Is there any comment on that? Okay. And so how about the inclusion of the Joint HHS Oversight Committee as part of this process? I think it's a good place to land a report on workplace violence. And if there are laws that are needed, it's the right place for people to consider whether or not there are new laws needed. I see you nodding. It's good? Okay. All right, so on the next page, the third page, I got into playing around when the annual report would be due. And this is just me sitting alone. So if you have a different opinion, share it, but I can tell you my reasoning. At the time, I thought having the annual report done at the end of December would be good, because by the time the budget process started, we'd have a current, fresh copy of a report. And so if there are any budget items, it could be addressed in the normal order. But I don't really have a strong opinion, other than I do think that we should be more clear on when the annual report is due.
Mr. Chairman? Oops.
Uh,
So is this the annual report for each facility or just one annual report from the commissioner?
I believe in this reference, this is meant to be the Commission on Workplace Violence, their annual report, and they would have to aggregate data from multiple institutions in order to do a roll-up, which is why I think I gave them some time to actually complete the report.
So let me suggest, if where you have changed shall to may there in the second line, that if you do that, what I'm afraid of is that there will not be standardization among facilities. If you say
Okay,
shall
so
include.
I'll give up on the shall. It
on
can
that
be
one,
a
yeah,
shall.
I just think,
I don't believe that standardization wouldn't work without it, but I'm okay.
okay, so let's change that back to shall if you don't mind.
Yeah,
Except Representative Irv has got an idea, I can see.
okay.
Can I just point something
You
out?
go ahead, Representative.
I just want to point out that this is not the annual report. This is one that's produced by each of the healthcare facilities. Number 4, which is what this references back to, says each health facility shall prepare and submit to the healthcare workplace safety, blah, blah, blah. So this is talking about what that annual report is. And I don't disagree that it shouldn't be date certain. You may want to actually say that for the calendar year ending December 31st must be prepared by January 15th or January 30th or something. So you have the whole full year to work with, full year's worth of data, and then the report comes out in January. Just a thought.
I don't see it, but I recall somewhere that I did set a date for when the report was supposed to be due elsewhere, but I may be wrong. I was getting punched happy yesterday. So, okay, so the next item, the incident including environmental and patient-specific risk factors present at the time of the incident, and then I added, as well as the appropriate categorization of the incident as workplace violence and or hostile words. The reason I inserted that is because I want these reports to be meaningful. And I don't want to have a definition where we're aggregating data into a category so large that there's no way to really interpret the data. So I'm suggesting that there should be categorization and clarity. Any comment on that? Any opposition? Okay. Next down, we're talking about classifications. I inserted, but not any identifiable personal information, because up above it had included the possibility of, or actually the requirement, that the names and job titles of employees involved in the incident. I want this stripped of personal data, and about the only exception I would include would be if there's a police report that gets attached, because a police report is, public information. And then I left somewhere in here, I talked about other governmental entity official documents, in case I overlook something with the police report. Is there any comment about making sure these reports are devoid of personal data? No? Okay.
Mr. Chairman, I just, I agree with everything you're saying, except I don't see in here where police reports are included. That's all.
I'm hoping to portend a future event, because I do believe it's in here somewhere, but we'll see. Okay, so I'm dropping down to little g. So the percentage of employees that have participated in the workplace violence program. Okay, so this was left ambiguous. So somebody could interpret it and say, every time I'm to include a percentage of employees, I need to calculate the most recent 12 months. And rather than having to do a constant recalculation every time they're looking at this, I'm saying that they should use the kind of a fixed percentage for their participation in the training and the like in the prior year. Do you have a comment on that, Representative Wallner? No? Okay. How about you, Sean? Do you have a copy of this? Are you tracking any of this? Okay. So this is just clarity and having to share the data. Instead of having to recalculate the data all the time, I'm saying just use a point in time from the report. Well, come on to the mic, because you're on YouTube. You're going to be famous.
Thank you very much, Mr. Chair. Sean Thomas from Demers and Praisall, representing the New Hampshire Nurses Association. So with respect to this, to G, the idea here is this number would only be calculated once and be included in this annual report from the facility to the commission. And so would be the percentage with respect to the entire year. So, if 95% of employees say had completed this training, the number then would be 95%. It's not per incident. It doesn't need to be recalculated each incident. It's just per report, which is once per year.
Okay.
And that may not be clear.
I think I tried to write it that way. If anyone doesn't think that's written well, Mr. Thomas just explained what I was trying to get at. Go ahead, Representative.
I think what he's saying is, recall, this is an annual report, so it's only being done once.
I know, but
Okay.
what they also are talking about incidences, and that every time, and you can have you could have 12 incidences once a month, and so this was just to clarify that when there's an incident, you're not having to calculate the percentage of the prior 12 months. You're supposed to go use the.
I gotcha.
Yeah, that's what I was trying to do. Mr. or Representative Weiler, yes, sir.
I predict that a minority of the people eligible to file reports will file the majority of the reports, and there'd be no way from this, the way this is written, to tell that that was the case. Thanks.
Is that a good thing or a bad thing?
Well, I think as an employer, you'd want to know if there's some that are very thin-skinned and see everything as an attack, while others are more tolerant.
I see what your point is. But because we have a non-retaliation clause in this later, it may make it better for the employer to not know from these reports who's creating the incident reports. The lack of knowledge could be a defense if somebody claims retaliation, but it's just a thought. That's brainstorming. The participation status of each healthcare facility eligible for active cooperation in this workplace program. So I think that's referring to the annual report, just a clear delineation by hospital name, who is involved, who's supposed to be in this program and who's actively participating. Again, the thought was a free market pressure campaign could be launched if somebody's not participating. There shall not be any identifiable personal information recorded in any report. Here it is, Representative Walls. Unless contained within an attached police report or other official report of a governmental entity. Violations may be adjudicated under the provisions of the right to freedom of discrimination in the workplace. I think that's the correct reference. But because I think it, Representative or Mr. Ripple, that's something you may want to highlight for OLS. I think that's the right adjudication, but I could be wrong. The next one, 7, Roman numeral 7. All persons within a healthcare facility are protected by the right to freedom of discrimination in public workplaces and education. That's a true statement. It's just adding clarity to the rest of it. No person or healthcare facility shall retaliate in any manner against any reporting individual acting in good faith. Mr. Thomas was earlier willing to accept the addition of the concept of good faith so that an employee couldn't kind of weaponize this reporting system just to create havoc. So this just says as long as they're working in good faith, they're protected. Any issue there? Okay. Dropping down. The Commissioner of the Department of Health and Human Services shall be responsible for maintaining an easily navigable, searchable, distinct page on the department's website to share information on the activities of the New Hampshire Healthcare Workplace Safety Commission. Topics to be included on the page shall include, but not be limited to, and then a bunch of things. But first is just the idea that this is in addition to the existing bill that we had, because I'm trying to create public pressure to participate and not just, a government mandate. Any issues with that? Do you want this on the websites or not? Why not? I hear. So what would they put on there? They would put a listing of all healthcare facilities by names with their business address included, which are subject to the provisions of this program that we're writing. They would include the participation status of each facility as active, opted out, which no longer makes sense, or unknown. I don't know. Opted out probably should be replaced with something like inactive, maybe. Since we're getting rid of the opt out. Do you see that, Mr. Ripple, that two, where it says opted out?
Very bottom of the page. Very bottom of the page, last line.
Yes, okay, I see.
Opted out, just make that inactive.
Change to inactive. Got it.
And if anyone has a better way of categorizing participation, I'm open. That's just
Can I say something?
what made sense yesterday. Representative Erf?
And Ms. Ripple, note that the old section 7 got deleted. That was the one that contained the fine information. That's where it's getting dropped out.
Okay.
Yeah, that's coming up here in a moment. The meeting date, the other thing that they'll report on the website is the meeting dates of each meeting of the New Hampshire Healthcare Workplace Safety Commission. I wouldn't mind if these were retroactive dates when the commissions met. I don't know that they need to be prospective because later in the confidentiality part, I don't think we're making this a public meeting. So posting dates in advance aren't necessary. I would want them to hyperlink access to each approved set of New Hampshire Healthcare Workplace Safety Commission minutes. If minutes of the meeting are not available, the meeting date will be listed with the statement minutes unavailable. So this raised a conversation about if these meetings are confidential, what would these minutes be doing? I think you could still write high-level minutes to inform the public of what's going on by saying, here's the date we met, here are the organizations that were present, here are the organizations that were absent. We talked about these issues, and these are some of the things that we think should be considered by the commission in the future or by the state with new law. So I think they can do high-level minutes without violating the confidentiality we're giving them. Any comment on that? Okay, so annually for the year ending in the calendar year, a press release shall be issued within 60 days highlighting the active participation of healthcare facilities and any major findings or recommendations. In the Army, they used to call these attaboys, an opportunity to publicly acknowledge participation and give thanks. I think they could be good press releases. And again, it's a source of public pressure. Any issue with including that? Okay, so I removed all the next, which had been in there, allowing discretion to the commissioner of DHHS to issue $2,000 fines. Comments on removing the fines? Mr. Thomas, do you have a comment on removing the fine?
Representative, we're okay with removing the fines if that means the program remains mandatory.
So far, have you heard anything to make you think that we're not going to make this mandatory? And I don't mean all the 42 conversations. I mean the public hearing today.
No, sir.
All right. Okay, thank you. You may as well sit there if you. Now that I can trust what you have to say.
Representative Edwards?
Yes, Representative Woolner.
Well, we've got Mr. Thomas up here.
Go ahead.
Are there any other pieces that we've just gone through? Particularly, I was wondering about all this policy for the Department of Health and Human Services and it on the website and all of that. Is there any parts of that that are concerning, or are you set with that?
obviously, I think primarily that's an issue for the department. I mean, what I would say specifically about that piece, and Representative Edwards already commented on this. I think specifically we were concerned with the meeting dates being included, with these meetings being confidential and not public, and why that would be necessary. And then why the minutes would be included. Presumably the minutes too would be confidential, but you know, he based on how he describes it, I don't think those seem to be non-issues at this point. It's a question now whether or not that's okay with the department, and that's not for us to worry about, but we're okay with it, with that piece being in there.
Is there
Ms.
any-
Minahan, did you have an opinion to offer? I'm sorry, I'll let you continue.
No.
Sorry, and I'm sorry I had to step out. I was running a Zoom down the hall. So I did talk with the individual that runs our quality program at the Foundation for Healthy Communities, and she's staff for the Quality Commission. And she is very concerned about all of that being put on the website. And because the entire process of the Quality Commission, which this commission is mirrored after, and we worked really carefully to mirror it. None of that should be, all of that is confidential, and it should not be on the department's website. There will be no public minutes. I'm not quite understanding where that came from, and I apologize. I did not hear that discussion point, Representative Edwards. So
I can tell you where it came from. I invented it because what I was attempting to do was to create a public awareness component of this commission, so that staff, patients, community members could be informed of what's going on, and that they could apply their own form of pressure to encourage the participation of the entity.
mhm.
So I'm okay with striking D on the minutes, because that was just an idea to, you know, if you want the public to move, you got to give them some information. So this was my thought, that the commission could decide what it may want to include in the minutes to demonstrate that they're a useful organization and that people should care about them. It was a marketing piece.
Thank you for that clarification. There is an annual report, as like with the Quality Commission. So I don't believe that is necessary. I also am concerned about adding the freedom from discrimination in public workplace references. My understanding from reviewing that RSA is that is for that does not apply to private entities. So I don't, and hospitals already are follow federal anti-discrimination. So I don't believe that is actually necessary.
I think that's a misinterpretation, though. RSA 354 covers the state, and it includes private entities.
Okay, that was not my reading. I cannot support putting that in there. Our position is the commission as drafted, we were supportive of, because again, we worked really hard on that entire drafting. I also wasn't clear why the annual report was being moved to the end of the year. And I'm sorry, I had to step out of the room.
I had explained that because I wanted the report done freshly enough so that it could be considered in the budget process. I'm trying to make it relevant.
Mm-hmm. And again, we support mandatory. We don't support voluntary. And I think we were going to look at.
Do you understand that we're working? So we're working from your original bill, and we're taking pieces of this and putting it in the original bill. So it is still mandatory.
Okay.
Minus the fines and.
Okay.
Some of the institutions, the small urgent care facilities.
Yeah.
You're here for that part of the conversation?
Yes.
Okay.
Yeah, I don't have an opinion on the urgent care centers. So I appreciate that if to take them out, they may or may not want to participate. I'm not sure. The hospital urgent care centers will, but
Okay, thank you. Were there any other questions, Representative Wallner?
Oh, I had a question about the calendar date of December 31st. You you didn't feel that was an appropriate date, or was it necessary?
well, the effective date starts in July of 23. So I thought we were going to be following that state fiscal year. That's why I thought I wasn't understanding why it was going to December. I don't know that that's necessarily problematic, except if it starts in July, I was thinking, do we have a short first year of 6 months report, or do we have an 18-month? That's why I was getting confused about that. I didn't understand.
I'd say yes,
Okay.
and it's probably going to take you 6 months to get all the carbon blown out of the cylinders to get the reporting going. Okay, any other questions? Okay, so the next one down, I have no, I don't really care about it. The members of the commission may ideally be composed instead of shall, and I just like if this is going to be a private entity, that they have the flexibility to do a little self-government, and if they had different members, then it's really not a state issue. But so I could see Mr. Ripple just keeping that as a shall. Then on duties down below, the duty of the commission shall propose changes, and this just changes who they're plugging into. Propose changes to the Joint Legislative Health and Human Services Committee and the Commissioner of DHHS. So so that there's a direct legislative communication. Is there any issue there? I'm not seeing any. The next one on the next page, D, probably should just be stricken, since we no longer have envisioned the possibility of an opt-out. On the chair, when they get elected, my suggestion was to have the very initial term of the chair be for 3 years instead of 2 years, so that you get into a method where you're always overlapping. An experienced vice chair with a brand new chair, an experienced chair with a brand new vice chair. So it's kind of a one-time deal to have the chair serve for 3 years and not 2, but subsequently 2. That's what that's intended to do. Are there any concerns? Anyone thinking that's a brilliant idea?
Yes.
Yes,
Yes,
that's
good
brilliant. Thank you. We're going to take that in testimony. Okay, so, but seriously, if anyone doesn't like that, let me know. Then in education, the chair will be this is an addition. The chair will be responsible for ensuring information intended for the public is transmitted in appropriate format to the commissioner of DHHS or designee. And again, the belief is that we want the public aware enough of what's going on so that the staff and the public can let the hospital systems know that they care about workplace violence. And that I deleted, and I have to think why, but I deleted all such information shall be disseminated through each participant's safety and security program. Well, I don't know that if we're saying each participant is supposed to have a safety and security program, or are we already getting too much into the internal affairs and operational structure of the members? It just seems like that was too specific. Your comment there, Mr. Thomas?
What I would say to that is that particular language comes exactly out of the Quality Safety Commission, after which this commission is modeled. So this is already existing language in current law. it's a process that is known and that protects the confidentiality, which is obviously of utmost importance in this case. And then with respect to the piece you added, the sentence you added above, I would only just want to reference down in section 7, 151J7. I think this is already addressed, where it says specifically, any information about processes or outcomes provided pursuant to this section shall be aggregate data only and shall not reference individual incidents, patients, healthcare providers, or institutions. So I don't know that it's necessary in this particular location as well.
Well, this has sort of got the opposite intent, though. This is meant to have the chair use the DHHS website as a way of being a beacon to the public about the program. This is the opposite of confidentiality. This is the chair deciding how to use the website process to get appropriate attention on this program. So just to get it out of here, the strike through from all such information through discussed, I could see just putting it back in there then. But do you still have a concern about the addition of the public transmission?
As I state, we do, the Hospital Association. Again, that is not the intent of the commission. That's not how the Quality Commission is structured. There is an annual report as stated, and that is how this information is disseminated. So we are not, I'm not quite sure how that all would work, but we respectfully believe that the reporting, the annual reporting, accomplishes the same thing.
All right. Is the whole annual report public?
Yes.
The commission's annual report.
So I
Yes.
thought this was such an important topic with incidences like 2 strangulations happening every month, you know, that there was more contemporaneous need for information sharing and public awareness. This was an attempt to help highlight the importance of this commission. You want to underplay that?
I am following Representative Edwards, all the work of the study committee and the experts that testified. And this is the approach that was agreed upon as I shared with you on Senate Bill 100's study committee report. So again, the Quality Commission has had 17 years of success, and that structure is what we respectfully want to follow. So I'm not sure.
In an
I'm
interest
just
of
not.
time, Mr. Ripple, just keep 151J4 education the same. No changes.
No changes to your proposed
No,
language?
to the way the bill came over.
Okay.
And then in confidentiality, all information other than public-facing minutes or police reports, and then it goes on. So it does allow that there may be a police report that could be included if necessary. Do you have a problem with that?
I would need to check with
Thank you.
folks. I'll need to check on that.
So down on 3, addition, this is about incidents where individuals are involved. Nevertheless, the principles of data minimization will be respected to include de-identification of any personally identifiable information. So far, we've said that that's the intent anyway. So, and under administration, added the phrase "and data privacy" to make the sentence, the final sentence on the page, read: "The activities of the Department of Health and Human Services and its employees or agents shall be subject to the same confidentiality provisions and data privacy as those that apply to the Commission." Going on to the last page, that's just an issue again with the when is the report due? Go ahead.
You might want to move that into January so they can capture all of the year's data. Is this the annual report you're talking about?
Yeah, like I said, I just threw a dart at that, and my goal in the big picture was just to have a fresh report for the budget process. So maybe that report is coming out, January 31.
Yeah,
Can,
January
can,
31,
can you
January
change that
15.
January 31 as of December 31st? Okay. Then such report may describe the activities of the commission. And I wanted to be able to say that we would indicate the institution's participation or their lack of participation if they weren't participating. So, so let's change that may there in the middle of that paragraph to shall. I'd like to keep the lack of participation listed as well. You have a problem with highlighting institutions that don't participate who are supposed to? I mean, that's the point of making this mandatory, right?
Right. So I don't know that it's necessary.
Okay. So then at the bottom of that paragraph, any information about processes or outcomes provided pursuant to this section shall be aggregate data only, shall not reference individual incidents, and then it closes with other than to identify the healthcare facilities. Oh, drop that. That whole black part there can be deleted. It's no longer necessary. On rulemaking, I deleted the phrase "and consent of a majority of the members" because the executive branch of the state government doesn't rely on the consent of a commission it establishes. So a smart commissioner will listen to the advice and then do the right thing. You have an issue with that? Does anyone have an issue with those things? So I think we've gone through this, Mr. Ripple. I think we've given you enough comments for an amendment to this. Oh, good point. Nice catch. There's one last one. On the effective date, I said it shall be repealed March 1st, 2024, 34. And that's just, that'll give it 10 years and people can relook it somewhere along the line. Representative Wallner?
I just wondered if did we come to a decision around taking out state facilities, or was that left?
I think we came to that decision. I
that's
assumed we came to that decision, but we can come back and clarify it. The whole reason finance is looking at it is because it's costing FTE per hospital for the state, and I just as soon have the state voluntarily participate without it becoming mandatory for the state. It doesn't say the state can't participate.
I just wanted to know whether we had how we had come down on that one.
So I think we said that the state could be excluded from the health facilities. But what is your opinion?
Well, I hope that they will volunteer. I do. I mean, I think that we could take them out at this point. I mean, basically, we're talking about, I don't even know if Glencliff really qualifies because it's a nursing home. And I'm not sure that nursing homes are covered here. Are they?
Let's ask the LBA rep, because this came from LBA language, right?
They're not.
They
Nursing
are-
homes are not part of this bill. You're correct, Representative Wallner. I'm not sure. Glencliff is a long-term care facility, so you're right. I don't know how that got in there. Honestly, I had nothing to do with the fiscal note.
Okay.
Mr. Chairman,
I had asked Mr. Ripple for an answer, so let's just give him a chance to respond.
I think you're right. I think Glencliff and New Hampshire Hospital, this bill likely would not apply to them even as written. That information was suggested to me today, so the fiscal note may have been an error in that respect, going back to the beginning.
And Hampstead also wouldn't probably be required to?
I'm not sure. I haven't had any conversations about that one.
Do you think it makes sense to leave some wording in there that lets it be?
Well, it's New Hampshire Hospital. New Hampshire Hospital would have qualified, right? New Hampshire Hospital would have been in the definition?
it depends on how they are licensed, if they fall under 151 or not. But like you said, they have probably the most robust program already. And hospitals have utilized their training programs. It's called, what's it called? Pam knows what it's called. Secure. It's an acronym. So they have had a program for a long time, and they do report on all sorts of incidences. So I don't obviously speak for New Hampshire Hospital, but I missed the conversation. Are you contemplating putting it in as an optional? Is that what you're thinking? State facilities
yes,
optional,
because
just
that-
make it,
that-
and then Hampstead could be
That
included.
takes the state cost out.
Okay.
Okay,
Mr.
so,
Chairman,
Representative Walls.
thank you. I'm wondering if we can add a provision in there that if a state facility is run by a private corporation, that they're then subject to this. In other words, if they contract Hampstead out,
Do we have one now?
no, but they're talking, there's before the executive council.
Can we
something
deal,
to-
can we
to-
deal with that when it's real?
It is real. I'm telling you that they're talking about doing it within the next month to make Hampstead run by a private facility. It's very real right now.
Do we know how they'd be licensed? Would they be licensed according to Ms. Minahan doesn't know. I don't know.
I'm afraid I don't know the
I would just
answer to
point
that
out, they're probably, whether I would qualify, they're not run by a private facility. The CEO, the CFO, all those folks, they're New Hampshire DHHS employees. It's below that, the contract picks up. So I
That-
imagine they would still qualify as a
that-
state facility.
That's true. The
one.
leadership
Okay,
is.
I had not seen the contract, but I was informed of it today, and that raised the concern for me that,
Yeah, no,
This
it's
is outside of the
partially.
contract.
We're gonna wait on amendment?
yeah, okay.
We're gonna wait on an amendment because I think we changed enough stuff that we just need to see it.
Mr. Chairman?
And then I would like to get to 275, and I'd like to finish 275 today because it's the only day it's on our agenda. Is your question important in this moment?
It is. I have one more question. In the version of this bill that we are turning out, is your definition of hostile words still included? Okay,
Is my definition of what?
hostile words. And Representative said yes. Well, to that end,
Well,
I would
that's,
just,
he answered for me, but my answer is, it's included in the draft that's gonna go to OLS, and they can look at the language, and if they think there's some smart lawyer way to describe the distinction between workplace violence and hostile words, I'm open to the smart lawyers.
well, let me just, I was doing a little Googling when we were here, and let me suggest the smart lawyers look at the definition of harassment and criminal threatening, because I think it's similar, particularly harassment, to what you're trying to do. And I just want to make sure we're not creating definitions that conflict with those definitions that are currently in the RSAs. That's all I was going to
Agreed.
suggest.
Agreed.
Thank you.
Representative Erf, did you have a question?
I was just going to suggest you ask Mr. Ripple about 275, because I believe he indicated that since you recessed it, you could pick it up again tomorrow.
That is true. And also, your revised amendment to 275 is currently in the works at OLS, so I think that probably won't be ready until tomorrow anyway.
We can talk about 275 tomorrow, and we're not violating any Paul Smith rules.
I don't believe so.
All right.
Mr. Edwards, could I see John Williams is here in the room.
Yes, and also Representative Leon, the vice chair of HHS, who did 459. So would you like to hear from Mr. Williams, or do you want to ask
Well,
him a question?
There's just one specific area I wanted to hear from. There
Come on
wasn't-
up.
There wasn't anyone in the room when we got down to, on page 2 of your, or page 3 of your amendment, when we got down to discussion draft, we got down to Roman numeral 8, the Commissioner of Health and Human Services shall be responsible for basically maintaining a website. And we didn't have anybody here from Health and Human Services to talk to us about whether that was, because this is all new, whether that was possible, impossible, would add cost. I mean, what does this all mean?
What Say again the page where it is.
Well, I think it's page 3. Your draft isn't, the number, there aren't any numbers on, it's right at the bottom of page 3.
Okay, I see it. So basically, Mr. Williams, this is just saying to give this commission a public face so that public interest and public energy and public pressure could be applied if hospitals are not participating, that the DHHS would use their website to host a page basically dedicated to this commission, and then it would meet the standards of any website, that it should be searchable, you know, the like. Do you want to comment on that? Because that is new work.
For the record, John Williams, the Director for Legislative Affairs with the New Hampshire Department of Health and Services. And I just, on a very high level, just want to say that our commissioner is in support of this very important initiative. I believe, Representative Edwards, there was not only a commentary that you had seen from the Health and Human Services Oversight Committee on Friday, but this is something certainly our agency would fulfill our obligations around the legislation. It's also acknowledged that because of the effective date being July 1st of 2023, unless in your amendment, and I apologize if it's changed a date, if that's the occasion, then the costs associated with this, and I would agree with Mr. Ripple that we need to provide you with a updated fiscal note worksheet, at least as it relates to New Hampshire Hospital and Glencliff Home, which Glencliff Home clearly, being a long-term care facility, wouldn't fall under this. But we could build in whatever costs associated with the bill through the budget process in the 24-25 budget. So the agency does support whatever iteration that you work out on this bill. We do also want to point out that the bill, as it came to this committee, still had components to it that would have some fiscal implications to the department. One would be the enforcement of the fines as it came to your committee, and the other piece, and it's out of here, and I like that. Very, very good for the audience. And the other piece of it would be, even though it doesn't use the words administratively attached to the department, in many fashions, the commission, the way the language is drafted, we would have to provide some level of support. But again, I say all of that with, we would work collaboratively with the legislature to build into the budget to accommodate for that based upon the effective date of the bill.
So after hearing you go through all of that, then you are fine with the department maintaining a website. That was my specific part about, that I wanted to know whether you were okay with that.
And Representative Edwards, I hope that the background I did provide was helpful, but yes, I did not directly answer Representative Wallner's question. And as we have worked collaboratively with the legislature in the past, posting on the department website seems not to be anything onerous at all. And in fact, I think consistent with our goals of promoting this particular initiative.
Great, thank you.
Thank you, Mr. Williams. Vice Chair Leone, have you heard enough of the discussion on 459 where if you could give us some words on whether you think what we've done here is consistent with the direction, if not the literal translation of the bill?
Yes, thank you, Mr. Chairman, and I did arrive just as you were beginning the discussion, so I was able to catch most of it. It looks like this has been a nice attempt to sort of soften those edges and get it more towards something that'll address the goals without that big fine issue. Anything that's in the licensing statute, we heard, is something that if somebody does not follow, it jeopardizes their license. So I feel that there's already a lot of heft behind anything that you're doing here in this section. That's actually why in the Senate they moved the Patient's Bill of Rights out of the licensing statute and put it in the Patient's Bill of Rights section so that it doesn't have the same heft and weight that it would in licensing. With that, having it as a may or having it as a shall for anybody that is more than 3 urgent cares does provide a good carve out now. I am concerned that that's going to lock in those small facilities as being 1 or 2 location only and inhibit their potential growth, because if a New Hampshire facility would need 1 full-time employee to implement this, I can only imagine that an urgent care would also need 1 full-time employee. So I remain concerned about the shall because of those small urgent cares. But I do agree that this is a very important program. I do have questions, though, as to if the strangulations happening at Dartmouth are already in violation of law. And if they are, how adding this is going to do anything to make them safer if those people that have strangled people at Dartmouth Hitchcock are not being prosecuted. Maybe there's a bigger problem that we need to address as well. So I guess those are my takeaways. I think you guys are doing great work. I probably might have
Can we
gone
assume
further.
that was rhetorical?
If you want, I was going to say, to my knowledge, the prosecutor, the question is, what kind of security is, they happen in the ER? What kind of security is in the ER to prevent them from happening? That was the question.
That's a really good facility choice. When I was down at Boston Medical Center, when I broke my femur, some of the people that came in with gunshot wounds from gang warfare were guarded there because that was something they needed to do to keep their patients safe. I hope we don't end up with lockdown ERs like you do down at Boston Medical Center. But if that is part of providing safe care, that's part of that duty of care, whether it's written into this law or not.
The way I recall it is because I used to work with hospital architects on re-engineering for image management networks, and so I had a chance to work through a lot of this. And I think there's like a JCAHO architectural standard of things that they should consider or contemplate in the design of their new facilities. And I think the security next to the ER has been a big thing for decades. I know when I started working in hospitals in 1970, they had the security right next to the ER. So, go ahead.
If I may, that actually brings up another big question. When reading through this, it says that if you're already under the Joint Accreditation Commission, you still follow that. I don't know if Dartmouth follows that, but as an institution of their size and heft, I would assume that they're JCO certified. So if they're already following a program that allows them to opt out of this program, I'm not sure how that would provide any more safety to this. I can't believe they were strangled there, but I don't know how this would provide any more safety, because those sort of things should never happen. But I don't think this would fix it for them if they're already following the joint accreditation.
You missed where we're going to add in nobody can strangle anyone in a hospital. That's in there. So
Nobody can strangle anyone anywhere, including a hospital.
No, especially a hospital.
Especially a hospital.
All right.
Perfect.
All right. So with that, are there any last comments? Anyone? We're gonna get what time are we getting tomorrow? 11:30. When?
Well, you have the full committee at 9. I actually have to check on tomorrow.
Yep.
But I will just add that I did receive the Senate Bill 275 amendment from OLS. So if you do want to do that today, you can do it today.
Let me check when we're meeting tomorrow. I think we're meeting at 11:30.
Brief discussion.
We got to be here at 9.
We're here at 9, yes.
So okay, so we're on the calendar for 11:30. Let's wait on 275. If you can distribute to everyone, and if everyone would just read what the amendment to 275 is, we can probably knock that out in about 10 minutes tomorrow. All right, I think that's a full day. So do I have a motion to adjourn?
So moved.
Second.
Second.
We are in adjournment. Or are we still in resource for 275? Yeah.